months or over another year, multiple training programs are going to happen, and then things will get into line. Any change definitely during the initial phase is definitely more challenging to implement. I'm sure all of us will have clarity in this shortly. So with that, I move on to the day's program. Thank you for contributing towards this OSCE. Dalvi sir, please.
One last thing, my suggestion, if anybody is involved in formulating this OSCE, the would-be examiner should appear for this examination first and pass it to know exactly what is happening. Then only
you as an examiner.
Pardon?
With you as an examiner,
we have to pass.
All. Don't worry. Thank you.
Sir, a little bit of information what I have is the subject standard is more clear, sir. There is no question about the standard of questions what is asked in OSCE. So I don't think candidate we are not going to ask something about interstellar stars or anything in the OSCE. We are going to ask about common surgical question. So I'm sure examiners may take only matter of 1 hour or so to get adapted to the system, sir. That is how I look at this issue. Sir, I'm sure, Dalvi sir,
I drive a small car. When you tell me to sit in a Mercedes and drive it, it's difficult unless I take lessons. So if you are changing a system, it is much better that the examiners are well versed with it. Prabal wants to say something.
Please, sir. Prabal, sir.
You can always, I've been examining the MRCS exams. And what they did when the first time that we had gone, they had a coaching round for all the examiners, the new examiners that they were taking in. And after you have done that training, it's an entire day training, then you go and sit with the examiner doing it before, and you are as an assistant examiner. And once you have done it a couple of times, then probably you get used to how the system runs. But the unfortunate thing is that this has its advantages and disadvantages. Both the advantages, it's a very fair system. There is no bias, as Dr. Rajagopal said. But the problem is that, as Khanna Saab said, that they're arranging 20 or 25 examiners at a time is going to be tough, real tough. Or you lower the bar for the examinership. I don't know how they'll move ahead. Probably there are a lot of small hurdles which they'll have to cross. And of course, as Dr. Dalvi said, training for trainers is very important before you take the exam. You cannot go and drive the Mercedes without having trained on it, sir.
The point
I think they have to get upgraded every 5 years in these countries, if I'm not wrong.
And there is a, tell me, sir, within 5 years.
Every 5 years, they have to upgrade themselves for renewal of license and everything, which we do not have the process.
Sir, I think now we are digressing into a totally different zone. Already this itself, I was not sure when students were requesting whether to bring it. Maybe that's the reason I called up all the faculty to request them to share their thoughts. But one thing is very clear. It is time, we have little longer time to adapt into the newer system. There are already, as Khanna sir said and as Chintamani sir said, already it is being implemented. It is not that somebody is going to implement tomorrow onwards. It is already being implemented. How well it is going to get implemented is only a matter of time and all of us to accept it. So with that, I close the OSCE discussion part of it. I warmly welcome today's faculty, Professor Satish Darab sir from Mumbai, from Professor Chintamani sir from Delhi, Prabal sir from Prayagraj, and Arunima ma'am from Tata Memorial Hospital, Jamshedpur. Warm welcome to all of you. To briefly address, the primary responsibility of asking questions goes to the invited faculty for the day. Other senior scientific committee members can definitely share their viewpoints after they ask. Priority for the first half will be on the history related questions. Second half will be for the clinical finding. And third half will go to the management. I think we have spent 45 minutes to 50 minutes on this. So I'm going to have a sort of a trial of an exam pattern today. So we will have 45 minutes for the long case and about 20 to 30 minutes for the short case today, because that was the suggestion which was given by all the senior faculty. In fact, we were debating last week whether to have one case alone, but everybody felt 2 cases are needed. But everybody insisted that time should be the essence of the success of the program. because I'm going to try enforcing that. Please bear with me if I'm cutting short senior examiners of time, because this forum has been very liberal on time. I would say at one point examiners pointed out, sir, there is a limit for being liberal. So it took 2 hours, 2.5 hours, 3 hours. And when it exceeded 3 hours, then everybody, all the examiners pointed out that important challenge everybody is undergoing. I think I stand with the words of the seniors who have advised me during the last end of the class meeting. So I will try to enforce some discipline on the timing today. Anyway, this OSCE has definitely taken good point. And I'm sure there will be people watching across the country. And to put on record, last class was watched about 1,250 people. Subsequent classes, I'm sure, are watched by many people. So I'm sure this message will reach the right people. And I'll also try to find out from the MCA what really is happening on that side. But National Board is going to have for the coming year. So I would request the examiners to take over. Dr. Veda is from Banaras University. Veda, please introduce yourself, your unit in charge, your department head, and go start your presentation. Over to you, Dr. Veda.
Good afternoon, everyone. Myself, Dr. Veda, JR2, Department of General Surgery, IMS BHU. I will be presenting a case, and it is moderated by Professor Ajay Khanna sir. And I work under Professor Seema Khanna ma'am, and my HOD is Professor Puneet sir. My patient is a 46-year-old gentleman, resident of Devariya, farmer by occupation, presented with chief complaints of generalized weakness for 6 months, pain in right lower abdomen for 1.5 months, passage of loose stools for 1 month. History of presenting illness. Patient was apparently asymptomatic 6 months back when he developed generalized weakness. He complains of easy fatigability at work, but he can perform his daily activities. History of loss of appetite for last 6 months. He has decreased the intake from 4 chapatis to 1 chapati per meal. And he also complains he has unintentional weight loss over last 5 months. Patient also complains of pain abdomen for 1.5 months, which was in right lower abdomen, insidious in onset, and it was mild dull aching pain, continuous in nature. There's no migration or radiation of pain. There are no aggravating factors, and it relieved on taking oral medications. A patient complains of altered bowel habits for last 1 month in the form of passage of fluid stools with frequency of 1 to 2 episodes per day, and they were mixed with blood occasionally on every 3rd or 4th day. And there is no nocturnal periodicity, not associated with alternating bowel habits or fresh bleeding per rectum or melena. No history of fever, cough, vomiting, or any swelling in the body. No history of any metastatic symptoms like jaundice, back pain, hemoptysis, chest pain, or headache. Past history, patient has no history of any comorbidities, no history of ATT intake or any tubercular contact. Personal history, he is addicted to chewing tobacco from last 15 years in the form of quid, and he is occasional alcoholic for last 20 years. He has normal bladder habits and normal sleep pattern. Family history, there is no history of colonic or any other GI malignancies or pancreatic breast or any other pelvic malignancies in the family. Treatment history, patient took oral medication for the pain abdomen for last 1 month. Summary, my patient is a 46-year-old gentleman presented with complaints of generalized weakness for last 6 months and dull aching continuous pain in right lower abdomen for 1.5 months associated with passage of loose stools mixed with blood for 1 month with associated loss of weight and appetite and no history of fever.
Here, I would like to ask you that you have said that the patient had passage of loose stool mixed with blood. Would you like to elaborate on the type of blood that was present in the loose stool?
Blood was altered blood. It was dark brown in color. And he passed altered blood every 3 to 4 days for 1 to 2 episodes.
So, and the quantity? Was it just cheeks or was it
mixed with stool? It was not significant bleed, ma'am. It was mixed with stool. He could see the dark brown altered blood in his stool every 3 to 4 days.
This is important because when you are saying that it was altered blood, you also need to see what the patient had as a part of diet, whether he is on some medication, some iron supplement or anything. because of which, because altered blood, patient commenting as blood in stool, that is not very normal.
Ma'am, patient complained that he could see dark brown colored blood like thing in the stool, along with stool, next to it.
What is the source of this blood?
Could you
From where this
could you
blood is
put it on
coming?
your? Can you stop sharing your screen so that we can see everybody? Could you
Yes, yes.
Said it is an altered
Yeah, that's
blood,
better.
and do you think from where it is coming?
From, it could be from small intestine or distal part of small intestine or proximal part of large intestine.
Why the blood from the small intestine is black in color?
Hello.
No, why
It's
the
brown in color, not melina as such. It is brownish blood.
There is no melina.
Blood.
Veda, one important history that I would like to take in such a patient. Can you hear me? Sorry. I think my connection is not very good. Can you hear me?
It is, yeah.
Sir, you are okay, sir. Perfectly okay. Please go ahead.
Right. One important history that I would like to get from this patient. Was there any history of vomiting? Was there any history of obstructive features, which you have not mentioned? And the other thing, any abdominal distension, history of abdominal distension. Those are some important things that I would like to know.
He's passing stool daily, loose stool daily. So I did not ask for any abdominal distension. He's not complaining of any obstructive features.
Vomiting?
No history of vomiting.
Right. Your patient must be a very intelligent patient, because usually a patient coming with history of 6 months with generalized lassitude and weakness is very uncommon in our country. A patient first in our place usually would come with abdominal pain when he first notices it. Is that history on a retrospect basis, or actually was it an actual history?
He came to the hospital after he developed pain. When he was feeling weak, he did not come to the hospital. When he started developing pain and loose stools, over last 1 month, he came to the hospital.
Here I would just like to add one more thing. Distension in abdomen is not really, it is not only because of obstruction. There are other causes also which cause distension of abdomen. So a patient having loose stool will not have distension is not a norm. The patient can have ascites. That also causes distension. So we are not talking just about gaseous distension. We are talking about distension in general.
Exactly.
So I think that is an important history.
Can I ask a question?
Please go ahead, sir.
Dr. Veda,
Yes.
you have already branded the patient is having a malignancy by making a statement which you should never do in the examination. No history of metastatic features. This is the first blunder which you should not do. You may be knowing that this is a case of Carcinoma Actinomycosis. It's a different issue. Second, how did you rule out tuberculosis? This is my second question to you. Did you ever ask history of fever?
Yes, sir. No history of fever.
Because you should specifically mention that when you gave a summary there, when a patient is 47-year-old male, 6 months history is there, loose stool is there, it's important that you rule out tuberculosis. That is number one. Yeah, please. So, trying to tell is, don't say no history of metastatic features, etc., when you don't even know what this patient is having. Other than we know that bowel, there could be a bowel involvement in this patient. And the cause for weakness is?
So he is having occult bleed, maybe because of the occult bleed.
Say anemia, that's all. You straight away say anemia. So what point I am trying to tell is, don't brand the patient at this stage as having malignancy. No, it is not correct. Yeah.
Satish Darup sir and Chintamani sir, I think you can take forward the next part of the exam.
I have a point to make. Whenever you get a lump in the abdomen and you have a thought process in mind, this is what is going to change with OSCE, let me tell you. Whether I think you made a good presentation and your history was quite nicely and nicely brought out. At the end of the day, suppose you make a diagnosis of malignant disorder or benign disorder or inflammatory disorder, as they're all discussing. You can't go back and take that history again. So rather than just saying metastatic history, therefore, for the benefit of doubt and taking the middle path, because always is always wrong, the middle path would be there is no history suggestive of, I mean, like, what would you ask in a metastatic history? Like jaundice, or you're basically, even if I have to support you, because I take the point which was made by Dr. Rajgopal, that you don't make it look that you already know it and you already committed to a cause or an etiology, because that's where people get a little disturbed. The surest recipe to failure is knowing the diagnosis, because then what you do is you call a problem that is fitting a square into a circle syndrome. So then you'll try to fit everything into it. So you did not even think about the possibilities of other disorders. There's nothing wrong in thinking about it, but bringing it out in the right way is important. That point I agree, and at the same time I agree with you. So take a middle path. That's one thing. And secondly, when you mention about the constitutional, about it, because constitutional will have the unique rise of temperature, night sweats, and other things that were covered. I'm not touching there. So basically, you should be able to communicate to your examiner that I'm thinking in terms of a GI disorder, that of the problem, and I'm thinking about maybe an inflammatory but also in the back of my mind. But what is in your mind should not come in the front as a blunt statement. You get the point? So please take that message home in that sense. Rest, I generally agree with what you presented. I'm similarly, as somebody said, when you're saying distension in relation to obstruction, see that intermittent obstruction is a feature of a particular disorder that you're looking at. You have to think of an intraluminal or pressure on the block. So obstruction becomes an important history in these patients, but bring it out in the manner that, you don't have to say distension not being there. It's not always with distension that obstruction would happen. Although classically it will happen that way. So I think you can be a little flexible with that. Right? Although with OSCE, you'll have it much easier because you'll be given 3-4.
What is this nocturnal periodicity, Dr. Veda? I have not heard this for stools. You mentioned it for stools. Can you explain a little better about that?
So when patient is having any diarrhea due to any secretory causes or exudative causes, patient will be having nocturnal periodicity.
I still don't know. We normally tell it for peptic ulcer disease. I don't know about this.
Hello.
Are you okay, ma?
Probably she meant that the spurious diarrhea or the mucus diarrhea maybe in the early morning. She gets regularly.
No, I think it is not a nocturnal periodicity which is there. Probably that she has taken wrong.
Yes.
If anybody has got the loose motions, and especially if somebody has to get up in the night to pass the motion, that's a red flag. Somebody may be passing 2 or 3 stools in the morning time, that may be just normal. But if he's also passing the night time also, he has to get up for that, that is abnormal. So that is a red flag sign which is there.
When Zanai asked, periodicity means there is a symptom-free period for some time, then there is symptoms comes.
No, I think periodicity is not a very correct word here in this.
Yeah.
Nocturnal diarrhea maybe.
Yeah.
So if the diarrhea occurs at night, it is definitely pathological. Like there could not be any other
that's the most
cause.
important. Yeah, sure.
That's the most important thing. Yes.
Yeah.
Did the patient had a pain?
Yes, sir.
Can you describe the pain we had?
The pain is pain in right lower abdomen for last 1.5 months, which was dull aching pain and continuous in nature, and it was not migratory or not radiating pain.
So are you expecting pain to be a migratory pain? Are you expecting a migration for this pain?
Sir, if it is due to any inflammatory pathology from the right lower abdomen, it will be mostly migratory. It will begin in the periumbilical region and then migrate it to the right lower abdomen. If it is due to inflammation of the bowel.
When you say no migratory, that is a precedence or antecedent? You are saying that's a pain in the right iliac fossa concern. Then when you say that is a migration, that means that is going for another place. So I don't think there's a word needed, but this point for migratory pain need not be put in here.
So to rule out any inflammation as a cause of the pain, I have asked with, for
migration pain in inflammation. Why do you get migration pain in inflammation?
Sir, initially the pain will be due to irritation of visceral peritoneum, and during that phase it will be radiating to the dermatome. Titan dermatome usually.
Please don't use that word radiation to. That is a daily different. Radiation to the dermatome. Don't mix the word here. As you said, it is rightly initially the visceral peritoneum. So the pain will be also visceral peritoneum. Any pain arising from the midgut will be felt in the umbilicus for the visceral peritoneal pain. Once it reaches the parietal peritoneum, it will be a skeletal nervous system and it will be localized exactly where they said. That is why you are getting that migrating pain.
Dr. Veda.
Yes.
Here you started as a good that dull aching pain. Your answer could have been simple, stretching of the capsule, or maybe some whatever in and around structures which are getting involved. Lumen is not obstructed. That is why there is no colicky pain. There is no distension, all that thing. And the periodicity, migration is only for acute appendicitis, that inflammatory. Why did you bring it here? 6 months old history, no. So don't get in trouble. That is what is important in the examination.
Veda, I have one small question for you. What is borborygmy?
So borborygmy, when there is obstruction, we can hear sounds, vowel sounds, peristaltic sounds.
So the patient hears sounds, right, in the abdomen. And colicky pain is different.
Yes.
Person with borborygmy in later stages will start getting colicky pain. So initial symptom is usually borborygmy. And whenever you are dealing with anything in the right iliac fossa, if you suspect that this patient is going to get obstructed, that one history I would have liked you to take. Next time you see that you include this, okay? Especially when you talk of mild pain and dull aching pain.
Yes.
I think she can go ahead with examination if we have to finish in 45 minutes.
That's what I was saying. Let's move to the examination. Veda, you can proceed with the examination, please.
Yes. Examination was performed after taking informed consent in presence of a male chaperone in the daylight after adequate exposure. Height was 158 centimeter and his weight was 55 kgs and BMI of 22. He has poor oral hygiene. Tobacco stains were seen and carries to the scene. He has ECOG performance status 1 and hydration was adequate. His vitals temperature is febrile and he has mild tachycardia of 110 beats per minute. His blood pressure was 120 by 64 mm of HG and respiratory rate of 16 per minute. Pallor on general examination, pallor present. There is no icterus, cyanosis, clubbing or generalized lymphadenopathy or pedal edema, and JVP is not raised. Left supraclavicular lymph node is not enlarged. Systemic examination is within normal limits in a CVS and respiratory system. On per abdomen examination, on inspection, abdomen is mildly distended, umbilicus centrally placed and inverted, all quadrants moving equally with respiration. Overlying skin appears no visible pulsations, peristalsis or venous engorgement or any scar marks. On palpation, local temperature is not raised, then there is no tenderness. A lump of size 8 into 11 centimeters is palpable in right iliac fossa, extending into the right lumbar region and umbilical region with irregular surface, irregular but well-defined margins, and the lump is non-tender and hard in consistency. and it is not mobile, not indentable, and it becomes less prominent on leg raising, and the lump is not bimanually palpable or ballotable, and there is no hepatosplenomegaly. On percussion, liver dullness is felt in 5th intercostal space, and liver span is 12 centimeters. Percussion over the lump is dull. There is no evidence of free fluid. On auscultation, normal bowel sounds were heard. Examination of back and spine, no spinal tenderness. Renal angles are not full or non-tender. External genitalia, bilateral testis is normal, and hernial orifices are intact. Diarrhean proctoscopy, anal tag was present and normal anal tone was present. No growth or pelvic deposits felt, fecal staining present. On proctoscopy, pale anal mucosa was seen and grade 1 hemorrhoids were seen at 3 o'clock and 7 o'clock position. Summary, 46-year-old gentleman presented with complaints of generalized weakness for 6 months and dull aching continuous pain in right lower abdomen for 1.5 months, associated with passage of loose stools mixed with blood for 1 month and associated loss of weight and appetite with no history of fever. On general examination, there is mild tachycardia and severe pallor present. On per abdomen examination, abdomen was non-tender with the presence of 18 to 11 centimeter intra-abdominal hard mass with no intrinsic mobility, palpable in right iliac fossa extending into right lumbar and umbilical region with no shifting dullness and no hepatosplenomegaly. And on diarrhean proctoscopy, no pelvic deposits and grade 1 hemorrhoids were seen.
Yeah, Veda, actually pretty nicely done. Most parts are covered as far as I'm concerned. And the point where you mentioned that on leg raising, it becomes less prominent. I think that's a method of finding out what you're writing eventually. So if you say there's an intra-abdominal lump, let the examiner ask you, how did you arrive at that? That's generally what I believe in. I mean, there's no point describing a test as a part of your presentation. This test is a tool to reach what you're saying, which you mentioned here. It's an intra-abdominal lump. Do you think it is intraperitoneal or retroperitoneal?
So I think it's a retroperitoneal lump.
Why?
Because not mobile.
Yes, not mobile.
Not mobile, so it's likely to be retroperitoneal lump.
And please, I'm so glad you did not mention knee elbow test and other tests because you don't need them here. And the other thing is very loosely taught. I mean, we all learn it in MBBS and we carry on all through our life. All quadrants are moving equally well with respiration. Actually, you also move with respiration. That's not exactly what the whole idea was. I mean, it was basically to look for a quadrant or a zone where there was inflammation that it won't move, patient will be holding it back. So when it is normal, it is normal. So but this is all right. This goes on. And I personally don't think left supraclavicular lymph node should be described in the journal examination. I will generally talk about generalized lymphadenopathy, and I will talk about the workhouse group of lymph node, which is incidentally not left supraclavicular lymph node. It keeps getting described that way. Which group of lymph nodes is this workhouse node?
It is between the two heads of sternocleidomastoid.
Scalene group of nodes. Left supraclavicular, now the AJCC 8th edition, even in breast, they've described it clearly so that there is no confusion. And broadly and loosely saying left supraclavicular lymph node, the left supraclavicular fossa is a part of cervical lymph node basin. So you should be careful about it. And therefore, it's a smart way to describe it. When you're finishing the abdominal examination, you describe DRE, you should describe the spine, and especially for me, I would be very, very, very open to that part. Everybody can challenge it. But right iliac fossa lump or left iliac fossa lump, lower limb examination is mandatory because movements at the hip joint, especially in certain conditions, could be restricted. There could be fixed flexion deformity. There could be pressure on the nerves, pressure on the veins, etc. So in a supraclavicular fossa lumps, we talk about the upper limb examination. The right iliac and left iliac fossa, we must talk about the lower limb examination, which is very, very important. Generally, that is what I wanted to convey, because a workhouse group of lymph node, the moment you mention, every examiner is going to ask you what is its significance in your case, and you'll get some questions to answer. Please remember, whether it's OSCE is different, but otherwise, a question and the answer that you give should lead to another question, which you hopefully can answer. That's the art of appearing in the examination. So always don't try to come out with like straight leg raising test, it became less prominent. Say intra-abdominal lump. Let the examiner ask you, what did you do for that? Then similarly, workhouse node, you started off right in the beginning. There's left supraclavicular node is not enlarged. And the term we use is not palpable. Sometimes they are enlarged, but you can't palpate them. So what you cannot appreciate is not clinically not palpable, is not palpable. Now, and DRE you described in details, which is an important part of the examination, spine DRE and DRE especially in this case. What intention did you have? You were looking for pelvic deposits and you were looking for anything else? What was your intent?
So to look for pelvic deposits and any rectal growth, associated rectal growth.
Any primary or another primary. And it is possible that left side, you can have a rectal growth and the right iliac fossa can be a presentation of that. Is that possible that the right iliac fossa lump could be due to a pathology on the left side?
Yes, so sometimes if there is obstruction, fecolith can get impacted in the right side.
It can be a cecal ballooning and fecalith can be palpated. And that's perhaps why you mentioned not indentable, which I appreciated, because that won't make it a very, very focused approach to what you're trying to say. All right. As far as I understand it, that you've taken me to a particular scenario and you want to discuss something. So I'll leave it to others if there's something else.
Two comments.
And then maybe we can move on.
2 comments on your last slide in the summary. You've said 2 comments on the last slide in the summary. One is you've mentioned about severe pallor. It's pallor, not pallor. And the other thing is, what is intrinsic mobility of a lump? What is severe pallor and what is intrinsic mobility of a lump?
So severe pallor, even his palmar creases are pale and all his mucus.
Pallor is present or it is not present. There is nothing as mild pallor or severe pallor or mild hint of slight pallor, right? So it is pallor is present. That is it, right? And the second thing is that what is the intrinsic mobility of the lump?
The lump is not mobile side to side.
Why did you say intrinsic mobility? Why no intrinsic mobility?
There is some upper.
Is it in all? Are there things in the organs in the abdomen which are intrinsically mobile? What do you mean? What do you mean by that? But like, what did you mean to say, or what did you convey?
There in upper quadrant lumps, there will be 2 kinds of mobility. One is moving with respiration, and other lump is intrinsic. Lump has intrinsic.
What I'm sorry, I'm butting in. Prabal has asked you for a very specific question. These terms are very, 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 very deceptive. Intrinsic mobility is not something that it's a mobile lump or it's a non-mobile lump. And moving on respiration is not mobility. Mobility is a sign. You illustrate that by doing yourself. Intrinsic mobility is a concept in organs like breast, where it's a mobile structure itself. You can move it. So there's some lump which is within the breast. So you fix the breast and then try to see it. So vis-a-vis the organ, it's mobility. Here the organ itself is the lump that you're talking about.
So what do you think this mobility would have been? Like which direction and which direction have you tried? Or is it a fixed lump, totally fixed lump and hard?
Actually.
This is a fixed lump. This is a totally fixed lump.
It was slightly mobile. What he's asking is what axis this would normally move in, if you are going with your hypothesis as the diagnosis that you have in your mind.
The side-to-side mobility.
Right. What is the attachment of the mesentery?
The mesentery, it starts from the transverse process of T12 vertebra and it extends on the left side and it goes towards the right side up to the sacroiliac joint.
It is
left a mark there, because, sorry, Dr. You can carry on. What I was trying to say was, to help her out, you must mention the exact point, right or left of the vertebra when it starts and it goes to the right sacroiliac joint. That's fine. Yes, sorry. Dr. Shenoy.
I just wanted to left of L2. What did you tell?
Yeah, same thing I was telling her. That mention of it. It's not T12. Yeah, and importantly, you should not say one vertebra and then you move to the right sacroiliac joint. It has to be from the left to the right. That's why is he asking? Can you read the mind of the examiner, Veda? By the way, let me check. Can you read the mind of what Dr. Prabal is trying to ask you?
To assess
why is he asking about the mesenteric attachment?
Mobility of the lump will be perpendicular to the axis of the mesentery.
So what are those lumps?
The mesenteric, this will be mobile. mesenteric cyst or any lump arising from the small bowel.
Right.
Can I tell you that the pallor, you said either it is present or not present. I think you grade the pallor, Pallor can be mild, it can be moderate, it can be severe. The mild pallor
So
is
what
when
is the
it is.
definition, sir?
Sorry,
Of a
yeah, I'm
mild,
telling
what is the difference of moderate pallor? How will you differentiate a moderate pallor from a severe pallor, sir?
I'm telling you that, yeah.
Palmar creases.
Mild pallor is when it is only of the conjunctiva or the mucous membrane. Moderate pallor is when it is along with the conjunctiva or mucous membrane, along with the skin. And if it is severe is there, it is skin plus the Palmar creases which are there. Okay, so if there are three things are there, conjunctiva, submucous or the mucous membrane, plus skin plus Palmar creases, that makes it a severe pallor. Okay, so if the candidate says there is a mild or moderate or severe pallor is there, I think she's okay with that, yeah.
Okay, point taken.
I have few points to ask to Dr. Veda. Number one, why did you tell it is a retroperitoneal mass? When the question was asked, it is fixed. Just because it is fixed, why did you tell it's a retroperitoneal? First question, answer that.
I said the location of the lump, that location, the lump will be either of cecal or cecal.
So
or
if the cecum, if they ask you, you say is retroperitoneal organ. Is it like that? Your answer will be in this patient.
Said it is not mobile lump, so it is
what?
in the retroperitoneum or it is fixed to the retroperitoneum.
So what you should have told is, because if you say retroperitoneal, people expect you, it's a not cecum, it is sarcoma or some lymph nodal mass or something like that. That is number one. Don't say that. Second, cecum is a relatively a fixed structure or a mobile structure, anatomical.
Anatomically, half of the cecum is intraperitoneal and the.
What I'm trying to tell is, if you look at carefully, this is a fixed structure. Small intestine is mobile. The question of mesentery and the mobility has been discussed. That is why I'm asking this question. So when you are talking about intrinsic mobility, hello?
Yes, sir.
You can hear?
Yes, sir. Yes.
Sir, you are with us, sir. Please go ahead. Satish, sir, I think you please take over. I think sir is disconnected.
Dr. Kanal, I would, am I audible?
No.
Very well, sir. Very well, sir. Please.
Okay, so actually part of the cecum is retroperitoneal, and a lot of cecal malignancies or ileocecal growths, even ileocecal tuberculosis can actually get fixed to the retroperitoneum. So I generally would agree with what she's saying, that if it is fixed and if it is not mobile, it's safer to err on the side of calling it, I mean, she can't certainly call it intraperitoneal. Clinically, she can't demonstrate any features which would make it intraperitoneal. Veda, am I visible to you or audible to you?
Yes, sir.
So, there is the reflection of peritoneum over the cecum. Part of it goes, and it's not mobile. Not all cecum is completely fixed also, but relatively, when ascending colon is retroperitoneal. So these lumps may not be moving because partly they become retroperitoneal. And your answer is well taken. If there's an intraperitoneal lump which gets fixed to the retroperitoneum also, that would be also not mobile. But then that you clinically cannot judge. So therefore, clinically, as far as you're concerned, you can't. You certainly have to be able to defend that. That's why you are being asked. Now, with this kind of a diagnosis and this kind of a clinical scenario, what is your impression? What do you think? What do you make? What impression do you make of it?
My provisional diagnosis is malignant etiology, probably CS cecum.
Whenever you're giving a diagnosis, Veda, it's a good idea to give a proper one. It will help you in long run. Don't come to the final word of it. Start with how old is the person? Say 50-year-old or 30-year-old gentleman or lady with a lump in the right iliac fossa, which according to you is probably malignant, and the cause being, what did he say?
CS cecum, carcinoma cecum.
Carcinoma of the cecum. And naturally, they're all going to ask you about why is it not any inflammatory pathology. So is there any differential diagnosis that you kept in mind?
It can be ileocecal tuberculosis. We need to
Now
do.
you'll have to therefore justify your first diagnosis. Why do you say it's a carcinoma of the cecum? I'll be quick with it.
Carcinoma cecum is my first diagnosis because patient presented with anorexia, weight loss, and anemia, and the lump, for around 6 months, and later he developed pain and altered bowel habits and associated with a lump which is hard in consistency and my first diagnosis will be carcinoma cecum, malignant etiology.
In the history, somewhere I lost connection. I probably don't know. Is there any history of melena in this patient?
No, no history of melanoma.
So is there a presentation like that? Because most of us remember the mnemonic for cecum is Lourdes, lump, obstruction, anemia, asthenia, anorexia, dyspepsia, and silent. It may remain silent for a long time, you know that. But is there any significance of melena in these patients?
So he has complaints of low stools with altered blood, with episodes of altered bleeding mixed with
So
stool.
what's your problem in calling it melena? Was there any discussion done on that, and that's why you're discouraged, or you think it is melena?
So melena is black tarry stool, but he's complaining of stool mixed with blood.
He can, if he could tell you about tar so clearly, then he would be a very intelligent patient, as Prabal was trying to also highlight. Now, how do you explain this altered blood coming? Where is it coming from?
Hello?
Where is this altered blood coming from?
Maybe from cecum, proximal large intestine or distal small intestine.
So they do have melena, and what is the alteration? What happens to the blood as it traverses through the large bowel?
So it gets digested by the colonic bacteria to hematin. Hemoglobin gets converted to hematin, which gives the blackish color.
Actually, this hematin thing is where you all get stuck, because you all go to stomach, acid, hematin, black cell discoloration. That's not always the case. Bacteria completely denature this. I don't know whether I'm audible, so I'm trying to finish as quickly as possible as I can speak. I lose connection maybe again. So there is a very thin line dividing this from the upper GI bleed, which becomes actually due to acid hematin, and such a long journey to go, long distance to travel. Bacteria do act in that case also. So do use that on your side. And then somebody asks you, what is the cause of lassitude? If this was malignancy of the cecum, is that just anemia or something more than that?
And,
generalized weakness, yes.
Anemia and also malignancy can cause some systemic inflammatory response.
Is that more common with stomach? More common with stomach and colonic growths? Yes, it is. There is cachexin produced because they're large. They can grow to a large size, and there is a central necrosis which leads to tumor necrosis factors being produced, which leads to actually cachexia. So they have this lassitude on account of both. So nutritionally they go down, and also they have a catabolic state that they are. That's what I thought. So you said ileocecal tuberculosis. The points in favor of malignancy you've told us. Is there any point to support ileocecal tuberculosis here?
Ileocecal tuberculosis will also present with these constitutional symptoms like anorexia, weight loss, but he doesn't have any complaints of evening rise of temperature, and also he doesn't have in ileocecal tuberculosis. Patient usually complains of abdominal pain, colicky type of abdominal.
See, something that Dr. Prabal raised, very important point. One important history that he said I would like to hear. With a lump of this size, ileocecal tuberculosis, what is it that the patient would be having?
Obstruction. He would have presented with intestinal.
Yes. So there will be features of intestinal obstruction, and that's probably where you are referring to distension. So,
Dr. Veda, I have one thing to say, that when a question is asked, why not ileocecal tuberculosis? Fever is not the answer because it is not mandatory, number one. Number two, you should say that the mass is very, very hard because your statements, it is fixed. And ileocecal tuberculosis mass is usually mobile, and it is higher placed in the little above in the lumbar region, and which will have a mobility. This is how you should argue in the examination. Fever is not at all required to make a diagnosis of ileocecal tuberculosis. Patient is only 47-year-old and he gives 6 months history. So based on your clinical findings of fixity, most important, consistency, mobility, fixity, you give a diagnosis. And in all patients with the lower abdominal masses, you should clearly mention the lower border is felt properly, especially in a woman, because it can be a carcinoma, ovary coming out, or some other pathology. And similarly, upper abdominal mass, you should say upper margin is felt properly. And about the mobility, that is the time I got lost. This mesentery related discussion came. Sigmoid colonic carcinoma will move according to the sigmoid mesentery. You know, it's sigmoid is mobile structure. Splenic flexure, hepatic flexure, you can't move, ascending colon, descending. Transverse colon will have vertical mobility because it is somewhere in the middle. And cecum, usually by the time, by this mass, it loses the mobility, but still will have some amount of sidewise mobility. And hepatosplenomegaly, don't make a blanket statement. This is a case of carcinoma. In women, you are expected to look for Krukenberg tumors also. So say liver, definitely yes, but adding spleen for this case is not required. You are a postgraduate now. These are my few observations. Thank you.
If you think it is a ileocecal tuberculosis, what type of ileocecal tuberculosis we are expecting? Hyperplastic or ulcerative?
Hyperplastic.
So do you think in this anorexia and all will be there in a hyperplastic tuberculosis?
So the hyperplastic patient will be nutritionally well-nourished patient.
So again, when you have a mass, most of the time it will be hyperplastic, and which will not have that, the more marked constitutional symptoms will not be there.
Yes.
And I think
what are the ways in which abdominal tuberculosis present?
Abdominal tuberculosis can be.
What are the various ways in which an abdominal TB can present?
Yes, abdominal tuberculosis can be either peritoneal or intestinal. Peritoneal tuberculosis can present acutely as ascites, as acute ascites, or it can present with diffuse fibrosis of the leading to the intestinal obstruction. Intestinal tuberculosis can be either hyperplastic or ulcerative. Hyperplastic, it will lead to the formation of, it will lead to clumping of the bowel loops, and also it will also present as a mass. And hyperplastic patient will be usually a nutritionally well-nourished patient, young patient. And
no, I'm not asking you. I'm not asking you to elaborate on all that. I'm just asking you, what are the ways in which an abdominal tuberculosis can present? It's a very simple question.
It can present with intestinal obstruction. It can present as a chronic abdominal pain with the lump. It can present as ascites sometimes.
Further to that, I would like to ask you, what is Tabes mesenterica, and what do you mean by subacute intestinal obstruction, which you often get in patients with tuberculosis?
In subacute intestinal obstruction, patient will have obstruction, not complete obstruction, but patient will be having recurrent episodes of obstruction. He can pass letters, but he can't completely pass the stool. He will be having episodic obstruction.
Sir,
now,
I think we have 10
Veda,
minutes to finish.
Just
one diagnosis incomplete, sir.
Yeah, exactly. That's right. Thank you. Thank you. And
So
Veda,
just before you move, I have one question, because her diagnosis is a carcinoma cecum. Is this a normal presentation of a carcinoma cecum? Loose stools, blood stained, blood in the stool. Is this normal presentation of carcinoma cecum, or how does a carcinoma cecum normally present? Because having alternate bowel habits is more of a left-sided tumor than a right-sided. So is it a normal presentation?
Normally, right-sided malignancy is present with anemia, anorexia, and lump. And some patients, around 15 to 30% patients, will have altered bowel habits.
okay,
What do you mean by altered
Veda,
bowel habits?
we got a diagnosis of carcinoma of the cecum. It looks more malignant, and let me just take up a couple of points that were taken. Ileocecal tuberculosis is obviously out of question, and I think you did cover that it's fixed, therefore you thought it's malignant. And The ileocecal tuberculosis is also not very freely mobile. Every lump in ileocecal tuberculosis is not pulled up cecums. It won't happen all the time. But ileocecal tuberculosis, assuming this large a size, would mean patient would have had obstruction. And there are things which are possible, but they're not probable. So therefore, as an intelligent student, you should be able to defend yourself by constitutional symptoms are important in ileocecal tuberculosis. Obstruction is important. In carcinoma cecum, it can be a huge lump and yet the patient may be silent. But like rightly somebody brought out, patients present with unexplained lassitude and anemia many a times. They may have no features to begin with. Altered blood is melena. Please don't get confused about it. And obstruction is obstruction. In such a large lump with ileocecal tuberculosis, you don't have a mobile lump. It's not possible for it to move. Ileocecal tuberculosis, before it grows to this size, would have presented as an emergency, and you know that. So malignancy is what is more likely. How do you proceed now? Your diagnosis is carcinoma cecum.
So first, I would like to do an ultrasound and to confirm whether it is a cecal mass or not. Then I'll go to confirm the diagnosis. I'll go for a colonoscopy if it is a cecal mass to get the biopsy. And for the staging of the disease, I will go for CECT of abdomen and thorax.
We're waiting, you can finish. You've done colonoscopy, you've taken a biopsy, and you did ultrasound as an extension of clinical examination rather as an investigation, because it will be very embarrassing. You put in a scope and the problem is outside. Can there be an extra mural causes for this? Can there be causes outside which can produce this picture? There are many issues. And why did I insist on the examination of the hip joint and the lower limb was that you must exclude other conditions. So there, rather than just harping on, when you think of it as a malignant etiology, tuberculosis is unlikely, but do discuss the malignant etiology in that region. There are other possibilities also, right? So therefore, you need to be clear. If you're thinking of malignancy, you're thinking of malignancy, then automatically your differential diagnosis would be of a malignant lump, right? Now you've done a colonoscopy, the biopsy is moderately differentiated carcinoma, adenocarcinoma. How do you proceed? You said you do the staging. Well, how do you stage carcinoma of the colon?
It's TNM staging. T1, the disease is confined to submucosa. T2, it invades the lamina propria. And T3, it invades through the lamina propria to the pericolonic tissue. And T4A, it involves the visceral peritoneum, and T4B, it gets adherent to the surrounding structures.
But yet, still it is resectable. So that's important to say. If it is fixed to a major vessel, that won't be the same. And how about the N status?
The N status is N1 is 1 lymph node, N2 is less than 3 lymph nodes, and N3 is 3 to 7 lymph nodes.
You've done colonoscopy to find out what the pathology is and to take a biopsy. What else you would like to look for in colonoscopy in these patients?
So we'll initially during colonoscopy, we'll see if we can reach up till the ileocecal valve.
No, that you've done. You've taken a biopsy also. Anything else? And don't just be fixed on ileocecal tuberculosis forever. See, that part is already off your mind. You've got malignancy, the diagnosis, such a large lump. It'll be very unusual, although tuberculosis can mimic many things. You've done what are you looking for in the colon in addition to the biopsy that you've taken?
Veda, you had half answered.
What else you are looking for in the colon in addition to the primary that you have seen?
Another
synchronous lesions.
Synchronous lesions, polyps or synchronous malignancy.
So please be clear on that. That's why the question was very, very focused. And it's a large lump. So what likely is to be the stage as far as you clinically think? Large fixed, large mass.
T3 or T4 lesion.
Not too far away, but it would be certainly about around T4. What else in CT you want to see? One is that you'll stage it. So you're looking for in any malignancy, it's a T for the history of T, history of N, history of M, examination for T, examination for N, examination for M, investigation for T, for N, for M. So now you're doing it for T and M. You have done it for the primary. Anything else you want to see around when you're doing a CT?
So we look for
N1C. Whether will you look for N1C? What is N1C?
So N1C is the depositions in the mesentery or in the pericolonic tissue, subserosal deposits.
So you
Okay.
you can examine that.
That's correct. Absolutely right. And CT is very, very sensitive for most of the lymph nodes, may not be for the primary. Now you would look for anything else in addition to find out whether the neighboring important and vital organs are involved.
We look for metastasis. We look for any ascites, liver mets, and
that you would have seen with ultrasound also. So what is it that you're looking for, especially in CT? Sorry, Dr. Abbe.
No, Veda, see, he's asking you a specific question. He's asking you, what are you going to look in the CT scan? Now, as a surgeon, you have to know whether you are going to cure the patient, you are going to resect the patient, or you are going to leave the patient to chemotherapy. So if you answer these three questions as you would look at the CT scan, you will get the answer.
Correct.
We'll look for if tumor is resectable or not, whether it is involving any major organs, whether it is adhered to any major organs.
What are the organs?
What are those close by?
What are those organs?
Can it be ureter, Veda? I'll help you. I'll quickly wind up because the time is an issue. You look for ureter, you look for surrounding structures. Which are the other ones? I've given you one hint. In the retroperitoneum, it can go further down.
So we can look for iliac vessels, where any iliac vessel encasement or any ureteric involvement which will lead to hydronephrosis. We'll look for the kidneys.
Madam, that's what I was asking.
You also have a fixed lump going right up to the umbilical.
After ureter.
Hello.
You said that the lump is extending right up to the umbilicus.
Yes.
So if you are going to look for iliacs, you are also going to look for
major aorta and IVC.
IVC. And when you do a right radical hemicolectomy, for that matter, only right colectomy, what is one structure which a senior will always look at when it is a fixed lump that you are likely to injure?
The ureter.
Apart from the ureter.
Ureter.
Apart from the ureter.
Ureter, you answered.
Any gastrointestinal structure that can come in your way of dissection?
When you're going up, Veda.
Yes.
So sit that.
Very good.
Duodenum and pancreas.
This cannot be done in, the OSCE.
I get your point, sir. I get your point.
Yes.
You on the
no hints.
Now, what about the adjuvant treatment? Last question, and I'll be done with it. What about, you've done surgery, margin? When do you say a margin is fine? How many notes need to be taken out? Can you come out quickly with that so that we can finish it?
5 to 7 centimeter margin proximally and distally is sufficient. At least 12 nodes has to be resected.
What do you understand by these terms? They're commonly asked by lots of examiners. Right hemicolectomy, extended right, radical right. What exactly does it mean to you?
The right hemicolectomy will ligate the ileocolic, right colic and the left branch of middle colic arteries. And in extended hemicolectomy, will ligate the main trunk of the middle colic artery. It means if
you ligate the left, you've already done it. So it's a right, you were saying earlier.
Right palm branch you ligate.
I think she went a step beyond earlier. That's fine. And the number of notes you mentioned. Anything in the histology, Veda, that will decide one is, of course, the grade and whether you got R0 resection or not, and the number of notes. Any other very specific test that you would do so that you can plan the adjuvant therapy in these patients?
It's microsatellite instability. We'll look for MSI instability.
Excellent. And which mutation you look for? Any particular gene?
It's a MMR.
Have you heard? Yeah, one of mismatch repair genes, but have you heard of KRAS mutation?
Yes, KRAS mutations. If it is negative, then we can give cetuximab to the patient.
That would be the targeted therapy, biological therapy. Now, last question, as far as I'm concerned, what are the regimes and what are their components?
So
generally, the number of nodes, Veda, are 15. Please remember that so that you don't get confused. It's not 12. And 16 in stomach, so easy to remember. So people say 15, so be clear on that. And a lot of people do they use indocyanine green to know the pattern in node negative. This is a large tumor. So Fossa and Fossa, please read about it. That's beyond the scope of discussion here. If there is a single metastasis in the segment 5 and this presentation, how would you approach the case?
So we can do metastatectomy. The patient performance, if this patient's performance status is good, so we can go for metastatectomy in this patient.
Is it a good idea to do synchronous surgery in both for the primary and metastasis, or you would like to put the patient on therapy and then see?
So if we are planning for a wedge resection for metastasis, liver metastasis, then we can go both the surgeries at the same time. Then we can go at the single setting. If we are planning any extensive surgery like right hepatectomy, then we'll first treat the primary malignancy and we'll go for the metastasis.
Veda, if I ask you a direct question, what is the best palliation for colorectal surgery, colorectal cancers? I've answered it.
The best palliation.
So you don't look for any other palliation. What is the best palliation for colorectal cancers? The answer is surgery, right? So whenever possible, we'll still be trying to resect it. So I think that by and large should be it. Any role of radiotherapy in colonic cancers?
No, sir.
What do you understand by the term CME? Like you have TME for rectum. What do you understand by CME?
Complete mesocolic excision.
What is that?
So in this, we try to ligate the vessels close to the origin so that we remove all the visceral mesocolon without reaching the visceral peritoneum.
There's something beyond it also which you should read. But this question is generally asked when you've done well. So as far as I'm concerned, you've done very, very well, exceeding. Congratulations. Thank you, Doctor.
Thank you, sir. Give us a few minutes for the other examiners to close. Satish, closing comments.
Hello?
Yes, sir. We are with you.
Yeah. So your lump was fixed, right?
Yes.
Hello. So you expect operative difficulty. So what is the role of pre-operative neoadjuvant chemotherapy in this case?
In CA colon, there is no documented proven role of neoadjuvant chemotherapy. Upfront resection is recommended.
Complete that way. The upfront resection is recommended as long as you can get an R0
resection,
which is possible. Therefore, they're asking you, you should in CT be able to see the extent of local infiltration into the retroperitoneum, into the psoas and ureters. Therefore, you need to be careful about, and you can do an R0 resection. Then upfront surgery is the best option. And you're right, neoadjuvant chemotherapy has limited role. But if you don't have a choice, then you don't have surgery possible. If you can't get an R0 margin, then you don't call it neoadjuvant in that case. You call it primary chemotherapy. Primary chemotherapy means as a primary modality. And then the surgery that you do after primary chemotherapy for remnant or recurrent disease, what do you call that? Salvage surgery. So that is the difference for remnant and recurrent surgery. So therefore, neoadjuvant, rather than neoadjuvant, primary chemotherapy, if it's not resectable. But if resectable, surgery is the best option, as you very rightly said.
Dr. Arunima, ma'am, do you want to give any closing words? Ma'am, may you please unmute yourself, ma'am?
We have covered most of the aspects. Just one more aspect. What is Turnbull technique in when you're managing a carcinoma?
Ma'am, in Turnbull technique, we'll first ligate the vessel so that the tumor spread doesn't occur, and we also clamp the bowel before we resect the bowel.
Veda, I'll help you. And Arunima will bear with me. I'm betting in. Now, the first thing you should say that it's a no-touch technique. It is not practiced anymore. It has not been found to benefit in any way. But yes, in laparoscopic surgery, a lot of people would like to do it that way only because it is easier to handle the bowel. Otherwise, it will fall on the scope. So, Turnbull is no-touch technique. So, before you get on to describe what you did very correctly. So, I thought I'll just butt in there.
Yeah. No, so you are absolutely right. I think in laparoscopy, we do have that medial to lateral and lateral to medial. So, people still use a Turnbull technique. Does happen there.
Thank you, Madam Sir. Prabal Sir, you want to give any closing words before I move on to the next case?
Veda, you did fairly well. What I would also like to comment is that apart from your main diagnosis of carcinoma, you should also be aware of the other things like abdominal tuberculosis or a differential diagnosis. You should be more wary about those, which you will not be able to answer very well. One question from my side: when you are doing the anastomosis, all the Turnbull technique has been described. The laparoscopic, you always take the vessels first because the bowel will fall back. How about the anastomosis? Is it what is the latest literature say about the best sort of anastomosis? Is it a handheld anastomosis or a stapled anastomosis is better? In a ileocecal CA.
Staple anastomosis is also as good as hand-seven anastomosis.
Yogi sir, I think I would request you to give in a statement-like format for the benefit of the students, and we move on to the next case. Regarding ileocolic anastomosis, what is the guideline or what is the safe way to do?
Sorry, who is this person?
Sir, I'm asking you to sum up in one or few lines, what is the right way to do an ileocolic anastomosis? Sir, Prabal sir, am I audible with you?
I can't. No, it's cutting. It's getting cut.
Okay. I would like you to tell what is the safe way to do a ileocolic standard anastomosis.
Right. If we have done the dissection bit, I'm not talking about dissection bit, whichever
anastomotic
way in open surgery, the anastomotic technique. When you've got the two ends of the bowel, if the mismatch is not much, which is usually not the case, then a preferred method is an end-to-end anastomosis. And now either you can do it by a hand anastomosis, hand sewn, or a stapler. The results of both have been seen to be equal in a carcinoma case. Whereas in an inflammatory bowel case, it's been seen that if you do it by a staple, the results are slightly better. Now, when you do anastomosis of the two ends, I usually do a 4-layer anastomosis. That is the outer layer with an non-absorbable suture and an inner layer with a absorbable PDS or a Weichel suture. Things that are important is that you have to see that there is no compromise about the vascularity at the ends of the lumen, which are most important, and that the two ends should not be under tension. These are two salient features about any anastomosis that has to be looked into, right? And there are very minor things, other important things, which would be, but this thing is that there's two things that we have to be very careful about is the vascularity at the end, and that should not be free of tension at the anastomosis.
Thank you, sir. Dr. Veda, you would like to ask some questions, or do you want to clarify something before I call the case to a close?
No.
Thank you. Abhay Dalvi sir, do you like to add something?
Not at all. Actually, just for PGs, I would only say because Prabal, one of the examiners thought that you could have answered the tuberculosis question quite well. So he is correct in asking you because deviation from the diagnosis is possible and you got to be ready for it. Now, for general PGs, let me tell you, tuberculosis abdomen, there are 4 types, but locally when it comes to intestinal, it's very easy. The patient can come with generalized just pain in abdomen without any signs and symptoms. But when it comes to local pathology, which keeps on increasing, either it will present as lump, which is hyperplastic tuberculosis. It will present in an ulcer, which will be with pain and bleeding as the presenting feature. And thirdly is the obstruction. So there are only 3 things which intestinal tuberculosis usually presents to you, and should not be difficult when somebody asks you this question if you have these 3 things in mind. And I'm quite sure in 3 years, you must have seen at least one of these 3 presentations to answer quite confidently. Dr. Dharap asked you about TB's mesenteric lymphadenopathy. It was supposed to be due to milk. And I think nowadays it's relatively age-old. Not many people see it. Yes, we see intestinal lymph nodes presenting as lumps. So remember that. Last thing, since you have done really well and you are worth 75 to 80% of the marks, I, as convener of examination, want to ask you, how would you describe a needle used for anastomosis between ileum and the colon?
We do two-layered anastomosis, seromuscular. We do
Needle. I want you to describe the needle.
half needle, half circle. It is 3 mm.
3 mm? What is 3 mm?
The length of the needle is 3 mm.
No. So my question to you, or rather when you do very well, you will be asked this question, because I have to give you distinction in surgery. And in surgery, resection is very easy. Joining things together is the most difficult part. And you got to know each and everything that you use. So usually it is 26 or 30 mm needle, 20 or 30 of delayed absorbable material or non-absorbable material. That's your choice. Okay. I'm not going further and asking you question on staplers. This is enough. So you are stuck with 80%. Thank you very much.
Thank you, sir. Veda, thank you so much. In fact, I would like to thank Khanna sir for giving this case. Then I also thank Dr. Seema ma'am and Puneet sir also. I saw Seema ma'am coming in. I think I lost her. Probably she got disconnected. Thank you, Seema ma'am and Puneet sir, for allowing your PG to be with us. Thank you, Khanna sir. Thank you, Veda. We look forward to seeing you sometime in the near future. This is the next case coming up from Professor T. Srinivasan sir's unit. Dr. Devika, can you please share your PowerPoint and introduce yourself, your chief, and start your presentation? Faculty, please take over.
Good evening, all professors, respected professors. I would like to start my presentation by quoting Sir William Osler: observe, record, communicate. Use your 5 senses, learn to see, learn to hear, learn to feel, and know that by practice alone you can become an expert.
The slide is not visible. The slide share. Make it slide share.
Share, sir.
No, you are okay, ma. You just make it bigger, make it full screen.
Actually, it's full screen in my. It's full screen, sir.
You have to go through the right lower end. Can you see one icon at the right lowermost end?
Share.
Share now.
You close all the tabs.
Yeah, you're okay. Yes.
Yeah.
Now
Go to the slide share.
Right lowermost, you have one icon. You see that right lowermost, like a cross. Yeah, press that.
Your slide show up style.
Okay, don't worry. You're perfect. Go ahead.
Sir, am I visible, sir?
Yeah.
Please go ahead.
Fine. Your first slide.
Yes, sir.
You introduce yourself.
Srinivasan, sir.
Good evening, respected professors. I am Dr. Devika Venu. I am a third-year MS postgraduate from Coimbatore Medical College, and I am fortunate enough to have my professor, Dr. Srinivasan sir, and my HOD, Professor Dr. V. Lakshmi Narayani ma'am, guiding me throughout this presentation. Coming on to history, a 52-year-old male patient belonging to low socioeconomic status, a coolie by occupation, presented with complaints of ulcer to the right foot heel for the past 1.5 years. History of presenting illness: he was an apparently normal person who developed an ulcer over the right heel region about 1.5 years ago. It was insidious in onset. Initially the size of a coin, which gradually increased over the years to present size. A painless ulcer at the beginning, which has become painful for the past 1 month. There is history of blood-stained, foul-smelling discharge from the ulcer for the past 1 month. History of blackish discoloration of skin around the ulcer. There is history of difficulty in walking. There is history of swelling in the right groin region for the past 2 months, which was initially small and gradually attained the present size, with no history of pain or discharge. There is no history of fever. There is no history of trauma or burns. There is no history of ulcers elsewhere in the body. There is no history of any loss of sensation. There is no history of breathlessness or bony pain. Past history, he has a history of pulmonary tuberculosis, which was treated and cured 19 years ago. He is not a known case of diabetes mellitus, systemic hypertension, CAD, CTA, asthma, or epilepsy. There is no history of any surgeries done. There is no history of any drug allergies. There is no history of any previous irradiation. He is a non-vegetarian. He is an alcoholic and smoker for the past 15 years. He used to smoke 20 cigarettes per day, accounting to 15 pack years. History of betel nut and tobacco chewing. He has normal bowel and bladder habits. He is married and has 4 children. Family history is nil significant. On summarizing, a 52-year-old patient, alcoholic and smoker, with a history of pulmonary tuberculosis, treated and cured, with complaints of discharging, non-healing, now painful ulcer for the past 1.5 years, which was insidious in onset and gradual in progression, with history of swelling over the right inguinal region.
I would request you to finish, ma'am. Being a short case, you go through till the end, let the examiners ask questions.
Okay, sir. Okay, sir. Moving on to the general examination, the ECOG score of the patient was 2. He was moderately nourished and built. He was anemic, not icteric, no clubbing, no cyanosis, no pedal edema. There was no generalized lymphadenopathy except the inguinal nodes, enlarged inguinal nodes. His vitals was normal. The systemic examination, CVS and RS was no abnormalities was detected. Her abdomen was soft, bowel sounds was heard, and no mass palpable or no organomegaly. CNS, there was no focal neurological deficit. An ocular examination was found to be normal. Moving on, the patient was exposed from growing down and examined in sitting as well as supine position after obtaining proper consent with adequate privacy. On inspection, multiple ulcers with irregular size and shape were seen with unhealthy skin bridge in between and over the right heel. The largest ulcer is of size approximately 8 × 8 centimeters, circular in shape, with well-defined irregular margins, varying edges. At some places, as you can see, we can see rolled out edges, and at some places it's undermined, and some places it's sloping edges. The floor is covered with pale granulation and slough with serous foul-smelling discharge. The surrounding skin appears blackened and thickened. There is no varicosities or lymphedema. Moving on to the extent, the medial border was approximately 3 centimeters from the medial malleolus. The posterior border approximately 2 centimeters from the intermalleolar line. The anterior border approximately 10 centimeters from the intermalleolar line, and the lateral border approximately 4 centimeters from the lateral malleolus. On palpation, the ulcer was non-tender. It do not bleed on touch. Other inspection findings were confirmed. Marked induration of the edge and the base was present. The surrounding skin is not warm or tender. No loss of sensation over the skin. The pulses were felt. No dilated veins, and the left lower limb was normal. The examination of the regional lymph nodes. Multiple inguinal nodes, hard in consistency, mobile, both transverse and vertical groups are palpable over the right inguinal region. The largest one measuring 4 × 3 centimeters. The skin over the swelling is normal. Multiple tiny nodes are palpable over the left inguinal region, which was mobile and firm as well. Popliteal nodes were not palpable. No other swelling were palpable over them. Summarizing, a 52-year-old male patient with a 8 × 8 centimeter ulcer over the right heel with irregular margins, rolled out edges, and with serous foul-smelling discharge with marked induration and enlarged right inguinal nodes. So my probable diagnosis is a 52-year-old male patient with squamous cell carcinoma of the right foot with metastatic inguinal lymph nodes. I would like to give a differential diagnosis of amelanotic melanoma and mycetoma foot. Moving on to the investigations, I would like to do the basic routine investigations.
I think it is a clinical case, so let's stick to that. Why do you think it's you made a good presentation and all aspects are covered and you examined the limb also properly. And your diagnosis is written on the foot, so there is no confusion about the diagnosis. Why do you say it's just an ulcer? You see a lot of proliferation also happening.
Yes,
So is it just an ulcer or there's a growth underlying which has ulcerated? There's a difference. That's why I'm asking you.
No, sir. As per the history is concerned, the patient clearly mentioned an ulcerative lesion. Sir, it started as an ulcerative lesion, which has progressed, which has spread over the heel, sir. So it was the patient has clearly specified it as an ulcer and not a nodule, sir.
You said there is a raised hepatitis, so it should be an ulcero-proliferative lesion, not
that's what I'm saying.
Okay, sir. Okay.
Absolutely. So it is much easier if you go to your picture. Can you show me the picture of your case? It's a classical ulcero-proliferative growth occupying most of the heel with induration that is crossing the. It's all right, Devika. I think if there's a difficulty, you can leave it. I remember and you remember the picture. So it's an ulcero-proliferative growth that is occupying almost the entire heel.
Yes, sir.
And then, excuse me, then you can describe the induration extending beyond the lesion, which has its significance. And otherwise, there is no problem with the diagnosis otherwise. So what about the surrounding skin? Do you see any pigmentation around?
Yes, sir. The surrounding skin is blackened, sir. It is blackened and induration is also present, sir. But it's not warm and it's not tender, sir.
How would you differentiate an induration that is caused by an inflammatory reason or the one caused by infiltration? Because the two are different scenarios. In malignancy, it's infiltration, and in simple benign inflammatory condition, it's just a reactionary infection, or even in a malignancy, there can be a secondary infection, and that induration could be different. So how do you differentiate the induration caused by malignancy vis-a-vis induration or hardness or the fibrosis or the thickening caused by inflammation?
So, I believe in all chronic ulcer cases, some kind of induration will be present over the edges, sir. But in case of malignancies, induration can be present both over the edges and over the base, sir. And the underlying bone might also be infiltrated.
See, I'll answer that question since I've asked it. That's my habit. Now, you should grab it quickly. Induration is a misused and a very loosely used term. It just had hardness in the base of an ulcer to describe the base, which is hidden. You can't see it. So when you palpate it, it is slightly harder than the rest of the limb in this case. So that will be called induration as far as you're concerned. In malignancy, it's kind of a desmoplastic reaction and also due to infiltration. And the induration in a malignant lesion would extend beyond the boundaries of the lesion. Now, induration in an inflammatory lesion would be confined to the boundaries of the lesion. And number two, there'll be local features of inflammation in an inflammatory swelling naturally. It'll be tender, there'll be local rise of temperature. So here, you don't have those features. So it's quite likely that it's due to infiltration rather than just inflammation. You agree, or you want to disagree on that?
No, sir, I agree, sir. I totally agree, sir.
Now, you've examined the heel, you examined the inguinal region. Yes. Have you missed out something? When you examine the limb as a whole, rather than just the hole in the limb. So what is it that you need to examine? And you kept that as a second possibility also.
Some melanoma, other...
So in transit nodules, and do describe the popliteal group of lymph nodes in these patients. It is significant. It's important to mention it. Rather than the varicose veins, which you highlighted, you should look for in-transit lesions, or how do you differentiate them from satellite lesions?
The satellite lesions are subcutaneous nodules which are present less than 2 centimeters from the primary lesions, whereas in-transit lesions are present more than 2 centimeters, but not beyond the regional group of lymph.
I'll just add one thing to that answer, that the concept is permeation, because there are two ways that cancer traverses in the lymphatics. One is by embolic phenomenon, the other is by permeation. And when it is going by permeation, you'll have it along the distribution or the direction of the lymphatic. So you will have one is the distance, the other is it will be lying in the direction of drainage. So this is how you differentiate the two. You have kept amelanotic. What was your differential diagnosis? You discussed 3 conditions. One is a squamous cell carcinoma. The second was
amelanotic melanoma, sir.
Amelanotic melanoma. And what was the third one?
Mycetoma foot, sir.
Now, can you justify the first one over the other 2 in a hurry?
Stop your slide sharing. Stop it.
You're doing fine. Why do you say it's a squamous cell carcinoma first and not a melanotic melanoma? Because you've given a differential, so you need to defend it. Otherwise, I thought one diagnosis that was working fine, but I am happy with your 2 differentials. So why is it not an amelanotic melanoma?
So first of all, amelanotic melanoma, it's rare. Squamous cell carcinoma is much more seen in kind of population, so much more common in the population. And even the duration is 1.5 years. And the patient doesn't have any other features suggestive of melanoma. So there is no pigmentation, there is no nevi, or there is no other symptoms which are suggestive of melanoma, sir.
Yeah, in your ulcer, you say surrounding there is a black pigmentation. A lot of pigmentations were there. It was almost the lymph was looking like a black surrounding that. How can you say it is amelanotic? If at all you think in terms of melanoma, why do you want to think in terms of amelanotic melanoma?
So melanoma, usually the floor will be blackened, sir. It will have a.
I'm not going to say it is melanoma, but when you say it is a melanoma, why do you think it is an amelanotic melanoma? What is the commonest melanoma?
Spreading and nodular, sir. Superficial spreading.
No, in India, for Asian countries, the commonest melanoma is not superficial spreading melanoma. There is a whole world, it is superficial spreading melanoma. If you particularly say in India, it is acral dendrogenic melanoma.
Okay, sir.
So you cannot put a diagnosis of amelanotic. If you would have just put as melanoma, it would have been much
better. Yes,
okay.
Perfect. That's precisely, absolutely, fantastic. Absolutely on the dot. So don't try to be very clever there by making it look like what you want it to look like. So malignant melanoma, and then possibly you could have discussed what are the possibilities. Then, of course, it's not a sun-exposed site. It's a common site for recurrent trauma. And you're fine with, mentioning that there was no pre-existing lesions. There are some changes that happen. Melanoma doesn't usually appear de novo, although it can. And what is the third one? You said mycetoma. Now, you'll find it very hard to defend, but you can defend it if you want.
So because
you get ulcer or sinus in mycetoma.
So it's a discharging sinus in mycetoma.
So, I mean, is there a long laundry list you must have for differential diagnosis, or you are happy with the first 2? Devika, you?
No, sir, I'm happy with the first 2.
Now, the third one is the trouble now. It starts very differently. And what else is there? There are multiple sinuses. What else is visible through these sinuses? What comes out and shines?
Sir, in mycetoma, sulfur granules will come out and yellowish granules will be present, sir.
Brilliant. So, do you think when you mentioned about amelanotic, you qualified it, overqualified it, that's why you got into trouble? Malignant melanoma is fine. When you qualified rare, is mycetoma very common? How many cases you have seen in these 3 years?
Not even one, sir.
So there you are. Common things are common, rare things are rare. But you should think about these things. Otherwise, you make them rarer by not thinking about them. So that's all right. But don't unnecessarily shoehorn a diagnosis, as they say. Don't put in unnecessarily.
Yes.
And it's not, and don't get into that, especially those books that guide you into there are 4 types, there are 6 types, there are 8 types. There are no such types. If your diagnosis is one, classically, it's an ulcer-proliferative growth with the everted edges, and you shouldn't be confused at all about it. You would say, that's my first diagnosis. I would entertain maybe a melanoma, which can be rare, but can be found in this case. What are the other features that support it to be a squamous cell carcinoma?
So clinically, it was a painless ulcer, sir. Only for the past 2 months, it has become painful. And the surrounding skin is also non-tender, sir. And the ulcer is having an everted edges, sir.
Why it is painful now?
Sir?
How does it become painful now?
So probably it must have, the patient might have perineural invasion or the patient might have bony erosions now. So probably that is why patient is having pain, because it is a long-standing ulcer of 1.5 years.
Also, one
What do you
point
think
in
about the
favor
lymph
of
nodes?
malignancy is that it came spontaneously without any injury, if I'm right. There was no history of trauma, you said.
No history of injury, history of
So
trauma.
it's unusual to have ulcers which come spontaneously without any history of injury.
Okay.
Now, you can also take into account the lymph nodes. And I particularly like, I must compliment you here, that when the answer is not according to what you want, you're very quickly willing to adjust, which is a good thing to do, and be flexible in your answering, because you can't be very sure about any diagnosis. And remember, the examiner is on your side. He wants to know what you know rather than what you don't know. And I think you know reasonably well about most of these things. Now, what is now your diagnosis is accepted. Now, how would you put a diagnosis properly, which didn't appear very proper to me, to be very fair to you. Now,
one question, sir. She said there is both horizontal and vertical group, and you examine the inguinal region. Is it that you examine the inguinal region, or where is the node now it is present? And how do you get a horizontal group nodes or a vertical group nodes you get when from the limb you have an ulcer in the lower foot?
Sorry, sir, I didn't understand your question, sir. Can you please?
You said both horizontal and vertical groups were involved.
Yes, sir.
And how do you get that horizontal group involved in ulcer from the lower limb?
So both the superficial group of lymph nodes, sir, and the lower limb will be draining into both.
No. Normally, lower limb drains into vertical chain, isn't it? When there are horizontal groups palpable, what does that mean? How is it going to horizontal group?
So the patient might have an added infection of the lower limb, and that might contribute to
No. Is it coming back to horizontal group from somewhere?
I don't know, sir. Sorry, sir.
I think this fuss about the deep and the superficial group, I think that was brought out simply to check whether you can stand it. You will find in lots of barefooted individuals, the superficial groups are palpable, and you must have done that many a times. So they're not always significant lymph nodes that you're referring to when it comes to superficial chain. And most commonly, it's a deep group, vertical group, which gets involved when the drainage happens from below up. So that part, that's what Dr. Satish was, that's what was highlighted. Can you answer that question for her? They don't have to come back from iliac region, but yes, superficial groups can be involved due to recurring secondary infection or trauma. Yes.
Yes, what I expected was probably if the iliac nodes are involved and it is reverse flow from there, and that is how
that goes too
horizontal
far,
chain is
actually.
involved.
You're right, but it's commonly it is you're right about the deep group being involved, and superficial is usually involved in. You must have seen it's very common in barefoot walkers. Most of our Indian patients will have a superficial group of nodes. Now, how do you proceed now? You've given us a clinical diagnosis. You must give a clinical diagnosis these days with a CT&M classification. You must always put a stage when you're saying it. Yeah, when you're giving a diagnosis for the benefit of all residents, always mention the age, the gender, and the diagnosis and the clinical stage if you can. And diagnosis should be both anatomical, physiological, and finally your stage. So can you give us the stage, Devika?
So my final diagnosis is a 52-year-old male patient with right foot squamous cell carcinoma of T3 stage, sir.
You finish and then we'll ask you? I didn't stop you.
Yes, sir. Yes, sir. Sir, squamous cell carcinoma T3 stage, sir.
That T3 is no stage. You have to get T&M, no?
T&M stage, sir.
No, what is the end stage? How do you stage squamous cell carcinoma these days according to AJCC 8th edition, SCC of the skin?
Actually, according to AJCC 8th edition, it is only for head and neck tumors, so they have not separated.
No, skin, it is there. No, it is given. It's cutaneous and you're smiling. I am telling you something which you should quickly grab. It's less than 2 centimeters, 2 to 4, more than 4. It's T1, T2, T3. T4 is any the contiguous organ getting involved, and that is divided into A and B, resectable and non-resectable. It's the same story. And then N0, N1, N2, and you should be aware of it. Actually, don't say there is only head and neck division. Head and neck is squamous cell carcinoma. The head and neck has been taken away from the major group, but skin cancers are staged, and there is a staging given there. Please read it because it's beyond the discussion in a clinical class. So you would give a diagnosis of 45-year and don't call male, female. That's a term used for animals usually. Give respect to your patients, gentleman or a lady, unless proven otherwise. Make it a point, 45-year gentleman with ulcer proliferative growth involving the right heel with a clinical stage CT3 and 1 M0 clinically. Then let the examiner ask you more beyond it. Dr. Satish, you were asking something. I think you raised your finger. I carried on. You can ask now.
I think in her clinical examination, she did not mention about fixity to the bone. Am I right, Dr. Devika?
Sir, I've mentioned about the induration. It's markedly indurated, but I've not separately mentioned about fixity to the bone, sir.
Yeah, that is very important because, yeah.
That's right. How do you proceed now? I think we'll keep it to a short case. We'll quickly move on. How do you proceed now? Your diagnosis is done. Your staging is done. Yes, Devika?
Yes, sir. Sir, I'll do my basic investigation, sir. Then I'll do an edge wedge biopsy to prove my diagnosis, sir. Then I'll take an X-ray of the foot, sir, which will decide the management. Which will decide the management. I'll do an ultrasound of the inguinal region, and I'll do an FNAC of the inguinal nodes, sir, whether to prove it's malignant or reactive nodes, sir.
Now look, Devika, if you're willing, I can help you there. In future, how should you answer? Because basic investigations are, nobody knows what are basic investigations, okay? So I generally teach my students what I'm sharing with you. You may like it, take it. If you don't like it, don't take it. Investigations should be divided into investigations to confirm the diagnosis, to support the diagnosis, to stage the disease, and then to treat the patient. To confirm the diagnosis, you'll be focused. You'll take an edge biopsy. Why edge biopsy? I'll ask you separately. And then to support it, and then to stage it, and then to treat the patient. So that puts it in perspective. Otherwise, people go all over the place. It may be some other case, and you would not know what are the basic investigations. So what would you do in the confirmatory investigations? I've already said edge biopsy. Why do you take the biopsy from the edge?
Because the edge is the most proliferative region of an ulcer, so that will prove if it's squamous cell.
Okay, and fine. But the most proliferative activity. And the second part is, if you take it from the center, there's a lot of necrotic material there. So you may not get the right answer. Cover both for everybody, right? So you've done an edge biopsy, it comes out to be equivocal. Pathologist says, I'm not able to make a diagnosis. So what do you think you can do so that it can improve your chances of getting a diagnosis? What is happening there? Can there be a secondary infection? The answer is yes. I'm trying to save time. So you'll repeat the biopsy after giving a course of antibiotics and local antiseptic dressings, and you probably will send it in 2 parts to 2 different pathologists, but that's not required. You can send it to the same pathologist. And what did you say you'll do for the lymph nodes?
The lymph nodes, I'll take an FNAC of the lymph nodes, sir. Because
Now,
since the lymph node goes across 3 centimeters, it's quite significant. I'll go directly with an FNAC of the lymph node. First, I'll do an ultrasound of the lymph nodes, sir, inguinal regions, and then I'll go for FNAC of the lymph nodes, sir.
What are the ultrasound features of a lymph node that make it metastatic? Please answer. If you don't know, you can say, I don't know. That's the best thing to do so that you get a question again. You don't know, Devika?
Ultrasound findings, I'm not sure.
Okay, now note it down quickly to save time because the other students also. First thing, as was brought out, you can't hear me?
No, sir, your video is not clear, sir.
Can you hear me?
Yes, sir. Yes, sir. Yes, sir.
Forget about the video. Can you hear me? Audio is important. One is the size. Second is the shape, right? The shape is it becomes spheroidal from its usual shape that is oblong. Due to central necrosis, it becomes spheroidal. That's number 1. Number 2, there will be central area of necrosis which will show up as hypoechoic area. Yes, number 3, there could be loss of halo. It's called halo sign. Halo is represented in ultrasound as a capsule of the lymph node. So if it crosses that, it's called a loss of halo. And finally, it is the loss of fatty hilum. So can you repeat those 4 points quickly?
Yes, sir. The lymph nodes become spheroidal, sir. The loss of halo will be there, sir. The central area becomes necrotic and becomes hypoechoic, and the last
Fatty hilum is replaced. If you have ultrasound features, you can do ultrasound guided FNAC. Most invasive investigations are now guided by imaging. Now, suppose you find it is negative and the primary is positive. A lot of people believe that in the presence of a primary malignancy, the lymph node is taken as positive unless proven otherwise. So when you put the patient on a course of antibiotics, if they were inflammatory, they should subside. Otherwise, you take them as probably metastatic. Now, any metastatic workup that you do besides this? You said something to do with CT, which I did not hear clearly.
Yes, so first I'll do an X-ray of the local parts. I'll do an X-ray foot to see if
good.
If it's involved, I'll do an MRI of the foot, sir, which is more valuable, and then I'll do a CT abdominal pelvis to check for other inguinal, nodes, metastatic nodes.
When you said X-ray, I was very happy, but when you came to MRI, it didn't make great sense. When you said X-ray, you wanted to look at any involvement of the bone, which is a good point. You do a good digital X-ray, and also you rule out osteomyelitis. And Dr. Satish Dharap was asking a very pertinent question. Is it fixed to the bone? Because that will decide what you're going to do about the foot. And actually, that is where you would try to do a contrast. You may do a CT, or MRI is usually for the depth of invasion, which you do for most depth of involvement or the plane of the swelling, which can also be done. But CT is more useful in these cases. But that's fine. You can do MRI also. There's nothing wrong in it. And for the lymph nodes, you've given a good and a reasonable answer that you do an ultrasound first. You do an FNAC, and if it is positive, you'll take it as involved, definitely. CT you want to do to rule out iliac nodes. That Dr. Dharap again asked a very pertinent question. Sometimes they get involved in continuation and you should be worried about it. Ultrasound abdomen is usually enough. You don't need a metastatic workup in all cases. So that you don't need CT thorax, which you very mentioned in a hurry. Now, with your diagnosis that you're given and the stage being given, what is the treatment for this patient? I'm sorry if I'm taking it fast for others.
No, sir, I think we will have to wrap up in 5 minutes.
That's why I was doing it in 2 minutes.
We're able to cover up everything. Please go ahead.
Thank you. What would you do, Devika? Please.
Proceed with the right below knee amputation of for this patient with the right ilioinguinal node dissection, sir.
You were very, I mean, did I hurry you up in answering that, or you take that decision regardless? If you do a CT and you find bone is free, if you find that MRI, the foot can be preserved, would you still amputate?
No, sir. If an X-ray there is no bony involvement, I can go in for a wide local excision, sir, giving a 4 to 6 millimeters of margin clearance, sir.
So, madam, if you had said that, that would have helped. If you had said, depending on my findings on CT or MRI or X-ray that I've done, I would see if I can preserve the limb. I'll try to. Amputation is not something you should speak in a hurry. At least that's what I would recommend. You said, but if you cannot preserve it, what would be the situation when it cannot be preserved?
So in case of bony involvement, it cannot be preserved. So in
Why?
case of
We can remove the bone.
No, bony involvement, you can correct and
remove the bone. We can remove the bone. Why do you say it is not resectable? As long as you can get an R0 margin and the functional limb, you will still do it. Heel can be removed. You can remove calcaneum. So your answer should be, look at the 3 things: neurovascular bundle, bone, or the joint. If any 2 are involved, you will not be able to preserve it. Isn't that easy? Neurovascular bundle, joint, and the bone, because it should be a functional limb that you're looking at. What did you say about the iliac block dissection? You will do routinely, or you do only inguinal dissection and then iliac dissection? Or you'll do iliac in all the cases?
No, sir. I'll do a right-sided right ilioinguinal block dissection in this case, sir.
What are the upper limits of what are the boundaries of iliac block dissection? We have only 3 minutes. 2 minutes out of 5 minutes have gone.
Sir, upper margin, the external iliac artery, sir. The lateral margin, genitofemoral nerve, sir. The lower margin.
Don't try to read around, because that's the worst thing to happen. If you know it, it's fine. If you try to read around notes and answer, that will not be the right way. The superior limit is bifurcation of common iliac. I'm trying to save time. Lateral is genitofemoral nerve. Medial is bladder. And the depth is obturator nerve. And then in the inguinal part, it's the apex of the femoral triangle. Laterally, it's adductor longus, sorry, sartorius. Medially, adductor longus. The floor is formed by pectineus. And from lateral to medial in the femoral triangle, you have nerve, femoral artery, femoral vein, empty space, and loose areolar tissue, what we call as naval mnemonic. Naval. Will you remember? Nerve, artery, vein, empty space, and the loose areolar tissue, the lymph node of Cloquet. Now, this empty space is through which femoral hernias happen, which when you read about femoral hernias. So this is generally what you'll do, but you don't do iliac dissection routinely. You'll do inguinal dissection, send it for frozen. If it is positive, you'll proceed with iliac dissection. Although I agree with you, in this case, it is very likely that you'll end up doing iliac block dissection. Suppose you had been able to save the limb and you dissected three-dimensional, you should say margin. When you say wide local excision, it will be composite resection because you'll remove the bone also, right? When you remove soft tissue with bone, we call it composite resection, and you can get a clear margin. If you're getting a clear margin, how would you reconstruct this defect?
So since it is at the heel, I'll go for a flap cover, sir. Isolated flap.
Excellent. Is that because it's heel or something more than that? Heel is correct.
The weight-bearing area of the body.
That's heel. So correct. Any other reason?
Because it's very close to the ankle joint also.
Now, what is this patient going to get in adjuvant setting?
RT, sir.
RT means?
Radiotherapy, sir.
Always say radiotherapy. So since the patient is going to get radiation, you can't put a graft there. You have to have a flap. So any idea what flap can be put here? If you answer that, I've given you distinction and I'll be finishing.
Sir, island flap, isolated flaps.
So if you don't know, you say you don't know.
No, sir.
So never try. What is a free flap?
Yes, sir.
What's a free flap, Devika?
So free flap is some flap which is free from the pedicle, sir.
What is an you don't know what that three types you should remember broadly. A random flap where you just rotate and you're not sure of the blood supply. Axial flap, when you know you rotate, you don't have known blood vessel and you're clear, like peculiaris major myocutaneous flap, tensor facial lata flap. And the third is the free flap, where you disconnect the flap along with its blood vessels and take it to the new site and do a microvascular anastomosis. Can you repeat the three types? Random, axial, and free.
Free flap.
Is that clear? And the adjuvant treatment we have already discussed. And you have any question to ask? As far as I'm concerned, I'm done.
Satish Dharab, sir, your few questions to close down. Sir, please unmute yourself, sir.
Yeah. So a couple of points. Any leg ulcer history, I think you need to include, rule out varicose veins, peripheral arterial disease, peripheral neuropathy, diabetes, lymphedema, out of which I think she did not talk about peripheral arterial disease and varicose veins in history. In examination, she mentioned that there is no varicose veins. Although the location of the ulcer is such that all these are unlikely, but nevertheless, for the sake of completion, should be mentioned in the history on any patient who has leg ulcer.
Yes.
Thank you, Mara. Thank you. Anything else, sir, you'd like to add, sir?
I would like to add one thing. Since we have talked about limb salvage surgery, we should also talk about the prophylactic irradiation of lymph node and intra-arterial infusion of chemotherapeutic agents in these patients, because that also has a role. And because just for completion of squamous cell carcinoma, role of sentinel lymph node biopsy.
I think I'll come in there, but it's important that she carries the message. We do sentinel node biopsy in N0 cases, so therefore that would be part of it. Isolated limb perfusion is usually done for melanomas. Nowadays, it's not even that is not practiced commonly. The classical answer would be wide local excision with three-dimensional clearance and iliac block dissection. And as far as the flap coverage is concerned, I think that part she covered. So I personally think she covered those parts which were necessary for the case. And as far as I'm concerned, I'll give her a reasonably good score there on questions that she answered. But there are many questions which were take-homes. Isolated lip perfusion is not commonly done for these cases when the inguinal lymph nodes are involved. And we don't have a prophylactic irradiation for inguinal lymph nodes. We give a therapeutic radiation in these cases because it's a resectable disease. And the answer is surgery followed by radiation. So they will be doing radiation to the, if you do amputation, naturally you've got rid of the disease. So you don't amputate a stump. Well, you don't irradiate a stump. In that case, we irradiate the inguinal lymph nodes. But the point is taken because in cases where you don't have nodal involvement, these are the conditions that you look at. Thank you.
Thank you.
Sir, thank you. Thank you, sir. Thank you, sir. I only asked her to put on the differential diagnosis. This is the guide's mistakes, not her mistake. So because there are multiple discharging signs, one thing plus because how you come and say no, these are all the points against melanotic melanoma, and it was me who guided her to put that one, number one. And the X-ray finding was the bone was destroyed. That's why she went straight away and said she didn't put the picture of the X-ray because I asked her not to pick the picture. So straight away she went and said an amputation. And the amputation was done today. Otherwise she would have. I said you should have. Mycetoma foot. I only brought in the diagnosis because you bring in the diagnosis. Somebody may ask why you can't, because there are multiple discharging sinuses. Thank you for the guidance, Dr.
I like to add something on looking at the picture. Looking at the picture, I also thought of mycetoma. I did not rule out. So that is a good thing. And the best part, Devika, you have the best guide who is ready to accept all what you missed on his shoulder. I think this scenario, you did excellently well.
Yes, sir. She has also just entered the final year in June 1st, sir.
Yes, sir.
She just
that's perfectly fine, actually, Dr. Srinivasan. I think
Thank you, sir.
we should be the take home should be clear to the candidate. They shouldn't go with 100 million differential diagnosis. Also, they should not have unreasonable ways to explain things. Certain things are very obvious and clear. But I think the differential diagnosis, the first two were fine, and I think we should be reasonable. If you have a presentation which is so classical and so obvious, sometimes speaking too much about too many things which are not likely also puts off an examiner. Certainly, a good examiner won't like to hear a laundry list of differential diagnosis when it is not making any sense. It's a classical case, so she presented it that way. But differential diagnosis is perfectly fine. But we should make too many differential diagnoses unnecessarily. So the candidate should be able to smartly deal with the differential diagnosis, because if you're saying something, you need to, like you rightly said, if you're putting mycetoma, you need to better work at it and should be able to deal with it. It's not that you just put a differential diagnosis straight out of the book, because practically a good examiner would also be aware of what exactly is the possibility and the probability. And they are all surgeons who are practicing. So they would be trying to look for those common sense answers. But well made. I think you guided her right. There's nothing wrong in the differential diagnosis, the first two especially. Because once you commit to a particular scenario, you should be able to answer that. But I think overall she did very well. Congratulations to you also, Dr. Srinivasan. Thank you.
Thank you, sir. Abhay sir wants to conclude, sir. Abhay sir.
The question is to the faculty, especially Chintamani sir. Sir, what is wrong if she, in absent, let's say there are no nodes, what is wrong if she says amputation with a good caliper if the patient is affording?
Actually, there is nothing wrong in anything, Dr. But there is these days the protocol is to preserve the limb as far as possible. Okay. If the limb is to be preserved, we should make sure it's functional. And it is with the 3 Ds of amputation, we still remember: dead, deadly, and damn nuisance. So I agree with you if the limb is so bad, like they amputated, but she should be prepared to, I mean, if you come out with an answer, amputation, then the general concept is that person is too preoccupied with getting the limb off. These days, people work at preserving it. Although the point is well taken, if she says it in the absence of lymph nodes and it's a lesion which is fairly resectable, they will jump to saying amputation even in that case. So that's where it is better that she says I'll amputate depending upon what I find on the investigations. And if I think it's not a useful limb, it's much better to have a functioning limb with a caliper with a knee joint that is intact. So the point well taken.
Okay, so for the PG, please see that if you are going to leave behind a non-functional limb, amputation still remains an option, but you got to defend it quite well. Ornima, it was a very nice interaction. There is a very nice video on YouTube, how not to confront an examiner. You did it 2 times. Number 1 with Dr. Chintamani, second time with Dr. Dhara. So I'm just giving you a clue how to not examiner the video for you to see. it gives you 10 things not to do.
You have such a pearls of wisdom. Fantastic. Absolutely fantastic. And it's off to you.
Yeah. So please see to it that don't confront. My last question, you started with William Osler. Who was he? Who was he?
Sir, he was a Canadian physician, sir.
And what was his primary specialty? He was a pathologist. First and foremost, never introduce yourself with William Osler or someone. Definitely not my name, but I'm just telling you, don't start your presentations that way. Since
he was one of the 4 founders of Johns Hopkins University. He brought the students from the lecture hall to the clinical side. He was the man who brought the students from the lecture hall to the clinical side, William Osler.
Sir, there is a lot to be read about Osler. That's not in the exam time. That's in the experiment time like me. Anyway,
since you asked, I'm telling you, I'm asking her to read.
Thank you.
Now tell me, you talked about Madura foot, and that foot had sinuses on the dorsum also that I saw. So considering that this was Madura foot, tell me something in short, 1 minute about Madura foot, because there is only one book, all over India that gives you a chapter on Madura foot. That is written by Dr. M.J. Joshi from Pune. I'm asking you this question specifically because this was a short case for me. The only time I saw it in the examination when I appeared for MS exams.
Just 1 second. Can I just flash my card for 1 second, sir? Sir?
Tell me something about Madura foot.
So it is a disease of the tropical countries, sir. It is caused by actinomycosis, sir.
It's okay. Since in 1984, it was a short case, and it was only because of internal examiner who took my examination I passed. Let me be very candid about it. Then I went back and read, and whatever I remember, I can tell you. Madura foot is, yes, it's a tropical disease, usually in a farmer who works barefoot. It is caused by 2, fungi as well as bacteria. Fungi are common in the north, which is a true fungal disorder. And in the south, it is bacterial, which is actinomycosis. This is all that I remember. And the treatment, I remember it as dapsone in my time and streptomycin. I think rifampicin is another drug which has been added recently. That you will have to read because often I cannot tell you much. I also do remember, I asked you this question specifically because it originated in Madurai, a state in which you are sitting.
It
originated in Madurai, in the state that you are sitting. So any person sitting in Tamil Nadu, if he's going to talk of Madurai, be very, very careful. Madura foot, be very careful. Okay? Thank you so much. God bless you.
It's the Madura of Varanasi only, sir, not Madurai of Tamil Nadu.
One interesting feature about taking it further, one interesting feature from Dr. Dalby's thing, actinomycosis is one condition which does not spread via lymphatics because the size of the actinomyces is larger than the lymphatics. So it will never have a lymph node metastasis. So if there's lymph node will never be present in actinomycosis. That is one. The other thing I would like in the previous case, if I am an examiner, of course, the main diagnosis we do discuss, but to know about the candidates, how much he or she has read, I would like to ask a few things away from your main case. So you should be prepared, like in the previous case, ileocecal tuberculosis should have been prepared well. And in your case, maybe a malignant melanoma questions will come on that. And tell me, what are the types of melanoma and what do you know about Clark's? Do you know about Breslow's? Do you know about HJCC? Have you read about it?
Yes, sir, I've read it about types of melanoma.
Okay, fine.
Nodular, sir. Nodular, superficial stage, nodular, and amelanotic melanoma, sir. And classification, it is the thickness of the skin or the melanoma measured.
That's fine. Yeah, okay. Okay, you've read. what is acral lentiginous and where does it start from?
So it is mostly present over the hands or over the
acral. What does acral mean?
periphery, sir.
Limbs. Acral, acromegaly, acral limbs, right? So acral lentiginous, where does it start from? Could this be an acral lentiginous?
Can be, sir.
It's commonest.
So it is a
maybe you give the answers.
Acral lentiginous usually starts from the subungual thing. This could not. This probably, if it is a melanoma, it would be a nodular sclerosis, right? Anyway, so my intention is just to make this thing that you should also know about the other diseases like say Madura foot or malignant melanoma or other types of skin malignancies. Right.
Thank you, sir. Kanna sir, your closing comments or questions?
I think in this patient, one of the very important thing which was there were multiple sinuses were there. That probably you never get in a patient with squamous cell carcinoma. There are multiple sinuses. And as this patient has a history of tuberculosis in the past, I think there are only two conditions where you get the multiple sinuses. One is actinomycosis, another tuberculosis. And in this patient, I think probably the patient might be having the actinomycosis, and over that, a marginus has come. So squamous cell carcinoma developing over the mycetoma is one of the features probably in this patient I can think about that. Because I have never seen a squamous cell carcinoma with so many sinuses which are surrounding that. So that has to be also one of the, because margins can come over the mycetoma also. It can come over the tuberculosis also. If there is a long-standing disease is there, it can come over that. So that has to be kept in mind in this.
One more diagnosis that I could have.
X-ray is one of the time with a very strong differential point. The node which present here will definitely is not in favor of actinomycosis or
absolutely not. And let's not.
Now the squamous cell carcinoma is developed over that.
No,
so
that's
what
fine,
about
right?
because the squamous cell carcinoma nodes are coming now.
What about the cutaneous lymphoma, sir?
Well, there are possibilities.
What about the cutaneous lymphoma?
There are 101
that is another
diagnoses there, and you can keep on speculating. What is likely is what you should look at. First of all, there was no sinuses there, and actinomycosis, as Prabal said, doesn't involve lymph nodes, and margins also does not involve lymph nodes. What is more clear should be discussed. Although it's a good idea to discuss a little thing here and there, but to go completely away from it also would not be really beneficial to the student. And there are possibilities which are definitely to be entertained. If the examiner is asking, she has no choice but to answer the question. There's no end to how many differential diagnoses you can have. You can just have an ulcer discussed. But a classical presentation of an ulcer, she gave no preceding history of any trauma. There was no scar there. She gave no history of sinuses. She gave a history of ulcer which was having multiple areas. So these are all possibilities, and you should be able to look at those possibilities. So Dr. Kanawil, I think there are feasible options with nodes of the kind she has described, with the ulcer, with induration of the base. I think there are too many points to address there. Mycetoma foot has appearance which occupies the entire foot, and there are sinuses with sulfur granules coming out. I have seen mycetoma foot. I have had the small series to be published also. It's not likely. And developing over a scar, there would be a scar first, and then it will develop an involvement of lymph nodes. Can happen in margolins if it crosses the scar and it invades into the deeper structure. So these are possibilities, but I think that's why she had kept the differential diagnosis at number 3. But I think it will still be a classical case of squamous cell carcinoma unless we want to make it more difficult. That's how it would be. Dr. Kanawil.
Yes, to get these answers only, I asked her to put the differential diagnosis. To get the answers tomorrow, if you sit as the examiner and ask why it's not mycetoma foot, she can say the answers. Yes. So that is why I brought in
You're right. It is possible also that there is mycetoma foot. It is also possible that mycetoma foot has healed, then the scar has formed, and the scar has developed marginal ulcer, which has infiltrated through the layers to involve lymph nodes. It's also possible that actinomycosis has got secondary infection, which has caused guanal lymph nodes, but these are not things that happen that frequently. Obviously, there's a classical ulcer-proliferative growth, and there are lymph nodes involved. I would take with a lot of salt if I have to
talk about
Okay,
other
sir.
conditions. And
Okay,
melanoma
sir.
is a possibility, definitely, which we should entertain. Thank you.
Okay, sir.
Thank you, sir.
Thank you.
Vivek, sir, you would like to add something?
Sir, shall I add some X-calculum? In established case of mycetoma, something looks different from the other malignancies. Whereas in squamous cell carcinoma, you do. Sir, can you hear me?
Please, sir, go ahead, sir.
Hello, sir. The classical X-ray of the limb, like particularly calculum, in established cases of mycetoma or actinoma, is totally different from the malignant involvement. Rather than a bony destruction, there is something like a radio denser and more cementing substances are added to the bone. So sometimes your X-ray also will tell you, in established cases of mycetoma, which differentiates from the malignancy.
Sir, there is periosteal reaction. You're very right in mycetoma, which
Yes,
along with features suggestive, very much like osteomyelitis. You can also have sequestrum. You can also have involucrum. You're right. It's possible on X-ray, but clinically, this is what you're right. X-ray can also distinguish the two.
Dr. Devika, do you have the X-ray, by the way?
Anagwell, one important thing is today all the PGs will once in for all go and read mycetoma.
Yes, sir.
I appreciate that, sir.
It's very rarely read, and suddenly if it comes up a discussion, at least the candidates will have read something to answer.
Thank you, sir.
It happened to me
Thank you.
before.
Thank you, sir.
Happen to anybody.
Thank you, sir.
Because it is not included in all the books that we read, this is a good read time for all of them. That's the way I look at it.
Robbins, I'm not sure present edition does it. The previous editions of Robbins' textbook of pathology had a definite last page of the fungal thing. This is discussed, sir, for almost a page length of text.
In second MBBS, when did you reach the last page of Robbins? By the way? Anyway, I have another meeting at 6 o'clock. So
thank you.
Thank you, Chintamani sir. Thank you,
Thank you, everyone, sir.
Thank you.
Thank you, sir. Thank you.
Thank you, Dr. Canavel.
Your
Can I
words?
leave, Dr. Canavel, now?
Sir, please, sir. We are winding up in 1 minute maximum. Thank you so much,
Please.
sir. Now I know why you don't want OSCE, sir. The amount of knowledge getting transferred is so high intensity. OSCE will never be able to meet up this level of intensity, I'm sure, sir.
Agreed.
Thank you so much, sir. Thank you.
Thank you. Thank you.
Kanna, sir, your words.
I think it was a very interesting case. There is no doubt about that. And I think the student has to put a good number of differential diagnoses here, Dr. Chintamani.
Yeah.
Because of the varying presentation here. It was a real difficult diagnosis which was to be made. Just keeping it as a squamous cell carcinoma only, and the patient and the candidate will get through, probably he will not. If I am the examiner for that, she has to give me the differential diagnosis of this, whether it is a melanoma, whether it is a mycetoma. Even I was thinking it is tuberculosis also at one point. Yes. Because she had a past history of tuberculosis. So she definitely requires a good number of differential diagnoses to keep her safe in the examination.
Sir, I'd like to add. Kanagwell, sir.
Yes, sir. Please, Andare, sir. Please.
This was a case of referral to third umpire, and the commentators who are bowlers were in favor of wicket given out, and the commentators who were batters are in the favor of batsmen given not out. This is what I'll say. It was a good discussion. I enjoyed it.
Thank you, Hitesh. Thank you.
David Kanagavel.
You're audible, sir. Yes.
Kanagavel.
Vivek sir is calling. Kanagavel
Can
is
you
not
stop?
there.
See,
Yeah, please.
Good, but in the examination during palpation, you was not saying about temperature, and you are saying only base present. What is the base present? Base attached or indurated with the deep stretches. Clinical findings very important. The examination, every examiner's clinical findings very important. Because the base is indurated with the deep stretches like muscles, tendon, bone, base that are not mobile. Like that, you have to say in the palpation, but you was not saying about that one. But anyhow, very good presentation, good answering. The examination, every examiners will expect it. Thank you. Hello. Kanagavel?
Kanagavel has left.
Kanagavel left. Devika, understand what I am saying?
Devika, are you understanding what?
See,
This is a learning curve. This is a learning curve for the PGs. You have to correct your mistakes. You have to correct your mistakes. You have to correct your mistakes. What your what Professor Vivek said.
The clinical clinical point of examination very important. Because short period they will expect that findings.
Yes, sir.
We know you have a theoretical knowledge well. Every examiner knows about you, but the time of presentation, the common sense, how do you apply? That is very important. All your knowledge, the time of presentation, how you are applying within the 10 to 15 minutes, that is very important, the examination. Like that, we will assess you have a clinical knowledge or not.
Yes, sir.
Otherwise, you are doing well. Congratulations.
Dr. Veda, do you like to ask any questions? Because we definitely give the opportunity for the students to ask questions. Do you have any questions, Dr. Veda? Yes. You are muted, ma. Dr. Veda, you are muted.
No, sir.
Thank you. I think Veda and Devika, I think, has a reverse similarity. I think I was just wondering whether it is a divine intervention that we had both girls together with similar names. So, Kanna sir, with your permission, can I close it a day for the day, sir?
Sure, definitely.
Satish sir, thank you for joining us. I think.
Thank you. I must congratulate both the presenters because they really presented well. And it requires a lot of courage, I would say, to present before so many examiners and such a large crowd.
Yes.
Good, well done.
Thank you, Satish sir. Thank you, Satish sir.
Thank you, Srinivasan sir. Thank you, Dr. Prabal, Dr. Jailal. Sir, I would like to request Satish sir, Prabal sir, or Jailal sir, maybe I need a few cases for the coming class. I think Dipendra has promised one case for the Friday. Dr. Sri Kumar was with us for some time and he has to leave. So Dr. Sri Kumar also, maybe one or two cases I may ask you to give the candidates for the coming week.
Sure.
So I think, but for the OSCE, we were able to finish the classes in time, 2 hours, because OSCE took 52 minutes. I went back to the recording, but then OSCE let the uncertainty be known to everyone. So something serious develops on that ground, as all the faculty here felt that serious training and efforts have to go in before making it a regular affair. I will take this message, and I'm sure all of the faculty here will also take the message before the National Medical Board it makes it a mandatory one. So with that,
Kanagavel sir.
Yes, sir.
You asked us to close the blacken the penis, isn't it? Suppose a case of carcinoma penis comes, how do we present it, sir?
Sir, that has been always a challenge, sir, because the first few classes we got disconnected. We were banned for 48 hours because I'm particular.
You can display 1 minute like that.
It has to be going off the screen in less than 7 seconds, sir. I went through the literature, but that is always a challenge because I will tell the student how to do that when you have a case of CA penis.
Yes, sir. We have got cases, sir. So that's what I'm asking you.
Ulcer itself marks the penis.
So even then how about breast also, sir?
We have problems, sir. Please understand, because this is watched by so many students during and after, because I would say 90% of the students watch after the office hours. In fact, when we were discussing last week, telling whether we have to limit the classes, Kanna sir was very particular that this pattern should keep going. I was also discussing with Dr. Vivek sir what to do, but then Vivek sir very firmly said, if every senior is telling, you have to follow. Andarya sir also was suggesting. In fact, we had a long discussion about it. But let me tell you, sir, there have been limitations, not because of us. If YouTube or Facebook bans us 3 times consecutively, then I have to remove the account. There is no way. We can always create a new account. But let me tell you, sir, the trust the students have kept on me. I have 2,878 subscribed PGs watching the program on a regular basis.
Thank you, sir.
Without subscription, another 1,500 to 1,700 candidates watch and go without subscription. I do want that trust which has been laid upon all the examiners from the beginning. I think 26th class we are on now. All the examiners have shaped these sessions into a very, very structured way. This is a unique platform, sir. I am not pressurizing on time, because when the intensity goes up, I feel bad to stop the examiners. Please stop there. This is for the candidates to learn the right way. And these are the limitations by the media, sir. Unless we govern the YouTube or Facebook, then we don't have these challenges of nudity. They have something different. Pornography, all those issues have been taken into consideration. Sir, for medical professionals, nudity is never a problem. From the day you step into anatomy, you don't feel you are covered or uncovered, but then we are structured by our seniors. Our faculty has guided us. What is the importance of having a female chaperone? Everything has been taught. But the YouTube or Facebook does not look at it, sir. In fact, we write to Facebook permitting medical as a special category. Then he said, that will be the loophole every phone channel will use, sir. We are not going to give it. I have a written mail replied from Facebook after we had a problem. Our Facebook account was frozen for 20 days, sir. That's why yesterday only I reactivated the Facebook, because of the first case which was shown for CA breast. Sir, you won't believe, sir, when abdomen is fully exposed also, they say more than 50% of the body exposure is nudity. That's the definition Facebook and YouTube gives. We have a different challenge, sir. I think we will have to limit, but I will have a way to expose this CA penis and breast cases. If there is anything, the candidate can directly reach out, sir. I will edit the presentation and help them out.
Yes, sir. We got presentation. That's right.
Chintamani, sir, you are back with us. I think we missed you in between. We are winding up the session, sir. Do you like to add anything, sir, before winding up?
No. Thank you very much. It's a great platform. And it made a lot of sense, and we can discuss it. Just think, I would like to say, Dr. Chintamani, we should have as many differential diagnoses as possible. I fully agree with them, but I think the 3 were good enough. So let's not have 4 or 5 or 10. You should also have a long laundry list. That's what I would like to say. Although I agree with them, if you give more differential diagnosis, some people would have an opportunity to discuss more. But many times it can be a disadvantage. If in a glaring case, you can give a differential diagnosis of something. I've observed people giving a differential diagnosis of an intra-abdominal lump with a retroperitoneal lump. Like they say a differential diagnosis of a stomach lump, then pseudocyst, then they say retroperitoneal sarcoma. So this can go wrong. But wherever it is possible and wherever it is likely and not making a huge difference, say in this case, all 3 differential diagnoses are fine. The candidate should learn to argue it out and discuss it out. Like Dr. Prabal brought out a very important point. When you're talking about actinomycosis, you're not talking about lymph nodes. Similarly, when you say marjolins, you're not talking of lymph nodes. And tuberculosis in India can mimic almost any condition. So you'll mention it, but you should be able to defend it. You shouldn't try to shoehorn a diagnosis. Don't create a scenario that it can be happening this way, then that happened, then that happened, then this happened. While the glaring finding is an everted edges squamous cell carcinoma, that doesn't look like a mycetoma. So therefore, it is healthy to have a differential diagnosis discussed, but don't have a long laundry list. I'm still addressing the students because they are annoying to any examiner. Sometimes it also reveals that one doesn't have the common sense to pick up what is more important. They're going to be masters of surgery, mind you. It's not an MBBS exam where they'll give 6 or 7 differential diagnoses just for the sake of it. If it is making sense, might as well have it. That's my take. At that time, I got disconnected. That I fully agree with what Dr. Ajay was saying, but at the same time, I wanted to put that rider. So they shouldn't go back home thinking that as many differential diagnoses, that is good. No, you have to be able to defend each one, and it should be logical, and you should be able to argue it out. Then it gives you a good opportunity to score by letting the examiner ask you more questions. Thank you, Dr. Kanavel.
Thank you, sir.
Have you passed my candidate, sir?
I've given your candidate 70% marks, doctor, and to you 75% marks.
Oh, thank you, thanks. Oh, all Mata Pita Guru Devam, sir.
Recertification of examiner is also permitted in this platform.
Important, yes.
Thank you, all of you, sir. Thank you, sir.
Thank you, sir.
I like to add comment, Kanagwil, sir.
Yes, sir.
Dr. Prabal, thank you very much. Good to see you on the screen.
At the end of this third year's tenure, probably they'll come to know what examiner, say for examiner Jailal sir, what does he expect? What does Khanda sir expects? What does Prabal sir expects? What Andare expects? So they can note it down from next class onwards, our lackings. And as always, heads off to Kanagvil sir. I am not visible, but I'll clap for him.
Thank you, sir. Thank you so much.
Thank you very much.
And I think, sir, it is a collective effort. I only make the connections because everything your efforts have grown it up to this standard of care for our class at least. I think it's a free platform where knowledge only plays, no egos, and every examiner is willing to listen to the other examiner. So let this culture keep going, sir. With that, I call the...
You are like Nokia, sir, connecting people.
Yes, yes.
Nokia first phone. You are like Nokia. Thank you, sir. Thank you, all of you, sir. Thank you, sir.
Thank you, Professor Satish Dharan. Thank you, Kanna sir. Thank you, Vivek sir. Thank you, Jailal sir. Thank you, Professor Srinivasan. Thank you, Dr. Prabal. Thank you, Professor Chintamani sir. Thank you, Devika and Veda, for making the session lively. I thank all the participants for making this event a grand show. And I'm sure you keep sharing this to your friends who are on duty right now, can be watched at a much later point of time. We look forward to have you in the next class. Maybe we have a parotid and one more thing, as I will confirm in the YouTube link. Thank you so much. See you. Bye-bye. Stay safe.
Thank you.
Thank you, sir.
Thank you. Thank you.